Dr. Kiran Kurtakoti. Everybody is here. We go ahead.
Good evening.
Yeah.
Good evening, Sneha.
Madam, good evening. Saida ma'am, welcome.
Saida ma'am, namaste, namaste and welcome.
Namaste, Saida madam.
Namaste,
Bharti.
Namaste ma'am.
Namaste, Saida ma'am.
Namaste. Saroj, namaste.
Dr. Sir, namaste, namaste.
Sneha ma'am, we are live now.
Okay.
Okay.
एक बार शुरू हो जाना फिर तुम चलो.
Okay, I am starting the webinar.
लैपटॉप मंगाओ नहीं आ गया
I would request all
लैपटॉप
of you to
क्या हो पहले तो क्या मेरे
all
लिए
of you to mute first and
लैपटॉप
then
नहीं ले गया
start.
लैपटॉप ले गया उससे कर सकती हूँ मैं भूरिया को है उसका ब्रेस करना है मीटिंग.
Good evening, respected faculties, delegates present over here. On the behalf of Corona Remedies Limited, I welcome you all for the Cure Connect live webinar in association with Amogs.
और अभी इधर
मुझे एक लैपटॉप भी लेना
I,
चाहिए.
Shivani Bhabra, welcome you all to the Cure Connect live webinar on association with Amogs EOC with UPCOG.
Shivani, will you please kindly mute everyone?
चलो क्या
Yes,
बात
ma'am.
ना 1963.
Hello, good evening, ma'am. Am I audible?
Yes, yes.
Okay, thank you, ma'am.
Shivani to introduce both the coordinators.
Okay.
Dr. Pragati, Dr. Nutan.
Okay, now I will introduce Dr. Pragati and Dr. Nutan. So, welcome Dr. Nutan, Dr. Pragati ma'am. She is the organizing secretary of UPCOG to 2024 and a vice chairperson of UPCOG Oncology Committee.
Okay, short introduction.
Yeah. Welcome Dr. Nutan Upadhyay, and she facilitated with the Hari Shankar Champion Award awarded under the Pradhan Mantri Surakshit Mantrivan Abhiyan.
I think Shivani, thank you for introducing us, and this is going to be a very, very pleasant evening. And I welcome our respected Padam Shri Usha Sharma ma'am. I can see Dr. Meera Agrothi ma'am who has joined. Namaskar and welcome ma'am. And warm regards to Dr. Chandravati ma'am who is not been able to join. And with on taking the blessings of my seniors, I would like to start this webinar. And it's always a pleasure to introduce dear Dr. Sneha Bruyer, who has been a very, very, very a hardworking and academician, and also a very, very magnetic person who has reached out to all of us. She has been a very, very active person who has linked especially UPCOG and Maharashtra. This is the second year of our webinars. We have had a successful season last year, and Dr. Sneha has been able to cover all our societies. And again, we are fortunate to restart this second series of our webinar. And Dr. Sneha is now running for the Vice President of Foxy, and she has lots and lots of accolades in her name. But the most importantly, she is Dr. S.N. Malhotra's individual national award, and many such awards she has taken from a Foxy society, and much earned. All the societies awards are much earned by our dear Sneha ma'am. So with all our wishes, we welcome Sneha ma'am to introduce the dignitaries of this evening. Dr. Sneha Buhar.
Shivani, please stop sharing. Please stop sharing. A very good evening to all of you. Please stop sharing. Shivani. A very good evening to all of you. My respect and regards to
शक्कर किसने है?
a
लो
very
बेटा
good
ये
evening to all of you. My respect and regards to all the seniors and mentors here. At the outset, I would like to welcome and thank Amogs office bearers, especially President Dr. Kiran Kurtakoti, Dr. Bipin Pandit, Secretary and Treasurer Dr. Madhuri Mendare, and of course the immediate past President Dr. Pardesi for the opportunity and free hand to work. I would like to thank all the three patrons of UPCOG, Padma Shri Madam Usha Sharma ji, Madam Meera Agnihotri ji, and Madam Chandramati ji. Today we are missing you, Madam, but yes, your blessings are always there, and thank you all for guiding and blessing me. I would like to also thank and welcome Madam Sarvut Singh, the President of UPCOG, and the entire team of UPCOG, and of course the Amogs office bearers. I thank all of you for having this collaboration with Amogs Emergency Obstetrics Committee. I welcome our chief guest as well as guest of honor, Dr. Archana Verma and Dr. Rajesh Modi. I also would like to welcome and thank Madam Professor Pushpa Somwanshi and Dr. Bharti Maheshwari for accepting the invitation to be the speakers, and Madam Pramila Mittal and Madam Saida Rizvi for accepting to be the experts for panel discussion on liver disorders in pregnancy. I also welcome and thank all the learned panelists, especially Dr. Manisha Gupta, Dr. Minakshi Rana, Dr. Sonal Agrawal, Dr. Vanashri Doifode, Dr. Sachin Gadekar, Dr. Rijul Agrawal, and all the president and secretaries of all the 8 societies of UP as well as Maharashtra. So the Firozabad team, Dr. Renu Gupta, Dr. Shikha Jain, Bishnu team, Dr. Beena Singh and Dr. Alka Bishnoi, Buland Shahar, Dr. Pramila Mittal and Indu Singh, and of course from Mau, our dear friend Dr. Ekika Singh and Meera Chauhan. From Akola, Maharashtra, Dr. Geeta Bhusari as President, Sachin Guibar as Secretary. From Ghaziabad, Dr. Alpana Agrawal and Dr. Chaya Goyal. And from Amravati, Dr. Poonam Belokar and Dr. Lalita Lokhande. And of course, our dear Madam Saida Rizvi from Faizabad, President, and Manjusha Pandey. So I welcome all of you, and I would like to welcome and thank all the hardworking, coordinators, Dr. Nutan Upadhyay, Saharanpur, and Dr. Pragati Agrawal from Bareilly. So with this, I would like to just, go ahead with the introduction of Madam Usha Sharma, because Dr. Kiran Kurtakoti is operating. He is in an emergency, so he will not be joining. So I just have Madam's blessing. So can we have Madam CV, please, Shivani? You have to be little fast, Shivani. So Madam, this is Madam's, domain, and everybody knows Madam so well. So she doesn't need a formal introduction. She's the chief patron of UPCOG, and of course, a very loving person, always blessing everybody. I don't want to read this whole CV, Madam.
No.
Yes, please.
It's enough. Hata do ise.
Yes, Madam. So that is your greatness, Madam. Just stop sharing, Shivani. We would like to have Madam's blessings directly. Just stop sharing. Thank you so much, Madam. Over to you for your blessings.
Thank you very much. Am I audible?
Yes, ma'am. You are audible,
Okay.
ma'am.
Thank you very much, Dr. Sneha. All of us know that Dr. Sneha is a very hardworking, dedicated, and a very learned person. And she is chairperson, Emergency Obstetric Committee of Amogs. And she has organized this webinar. And it really gives me a pleasure to be amongst you all this evening on the occasion of this webinar, which is being organized by Dr. Sneha and coordinator R. Nutan Upadhyaya and Pragati Agrawal. And they have chosen a very, very important topic for discussion today, that is hypertension pregnancy. All of us know that it is such a frequent thing which occurs during pregnancy, but is very, very disturbing, and sometimes it is very difficult to manage due to the consequences on the fetus as well as on the mother. And we don't have today Dr. Kiran Koti, who is the president, and Dr. Bipin Pandit is also not here. Dr. Rajendra Pardesi is also not here, but certainly we have Sneha with us, who is a very, very, I will say she is such a dedicated person that all the time working to just spread the knowledge to all the members of the Foxy. And then from this webinar, as we know, as she said, that she is organizing this webinar in association with Amogs and UPCOG. And UPCOG, we have got Dr. Chandravati, Dr. Raj Baveja, and my very dear Dr. Meera Agnihotri, who always, I say, she is like a second mother to UPCOG. And then we have our president, Dr. Saroj Singh, Secretary Dr. Bharti Maheshwari. Again, I will say that really Bharti is a very strong pillar of UPCOG. And I always say that she is another person whom I always find such a hardworking, dedicated, and sincere person. And I always say that few persons, when you meet them, you feel like that they are the real gems of Foxy. And she's one of them. Then I have very dynamic and dedicated and young, pretty Dr. Priyanka Garg as the Joint Secretary and Dr. Isha Kanuja as the Assistant Joint Secretary of UPCOG. And all of you know that we have advisor Dr. Narendra Malhotra and Jaideep Mitra with us. And today Meera is also with me as a chief guest of this program. And then we have guest of honor, Kiran, who is unfortunately is not with us today, and Saroj Singh, Dr. Rajesh Modi, and my very own Dr. Archana Verma from Ghaziabad. And all of you know that, Sneha, you have already tried very nicely that you have involved so many society like Bijnor and Bulandshahr, then Akola, Amravati, Ghaziabad, and Firozabad, Faizabad. It's so difficult to involve so many societies, but certainly the program will be very, very beneficial for everyone. And then we have a speaker with us like Dr. Pushpa and Dr. Bharti Maheshwari. And of course, the panel discussion will be moderated by you, where Dr. Pushpa will be speaking on prediction and prevention of HDP. Dr. Bharti Maheshwari will be dealing with the management of HDP. And we are having a panel discussion with worthy panels where we will be discussing the liver disorders during pregnancy. You have already selected a very nice topic, and I'm sure now I will be failing my duty if I don't name our very dear and dynamic chairpersons like Alpana Agrawal, Poonam, Reenu, and Saida. And then we have got Geeta, Ekika, and again the expert, we have Pramila Mittal and Saida Rizvi from Faizabad. So I'm sure that the deliberation today will go a long way in updating the knowledge of everyone, and everybody will be greatly benefited by this program. I wish this program a great success, and thank you very much, Sneha, for making me a part of such a prestigious program. Wish you all a very healthy, happy, and bright future. Thank you very much. Sneha, you please go ahead now.
Thank you, madam.
Thank you, madam.
And with this, I invite our patron of UPCOG, respected Madam Meera Agnihotri ji, Madam, we are eagerly waiting to listen to you. I mean, whatever CV I read, it is not sufficient to describe you. We are just eager to listen to you, Madam Meeraji. Over to you.
हेलो
Yes, madam. We are just eager to listen to you.
खूब सुनाई पड़ रही है अच्छी।
really obliged, loved and you see blessed to be with all of you. अभी उषा जी से मेरी मुलाकात हुई डायस पर, लेकिन इस वक्त मेरे चारों तरफ 25 लोग बैठे हुए हैं। तुम्हें घुमा के मैं दिखा दूं। Whole Cox is with me. Whole Cox is with me.
Hello, Dr. Kiran. Hello,
You can see
everybody.
Kiran Pandey. You can see Kiran Sinha. You
Yes,
can
great, madam.
हेलो
Kiran.
किरण
Can you see?
हेलो
चारों तरफ more than 25%
Okay.
are here to bless you and convey regards to Usha ji. So my blessings is not a single voice blessing, it is containing multiple voices. तो सबसे पहले तुम्हें मालूम है इस मीटिंग में मैं सुबह से बैठी हूँ, तो मेरी शक्ल देखकर अंदाज लगा सकती हो कि इन लोगों ने मेरी कैसी एक्टिविटी करी हुई है।
क्यूट हो रही हो मीरा।
सबसे पहले तो
You
ये
are as
बहुत
gorgeous
बढ़िया
as
प्रोग्राम है। आई कैन सी डॉक्टर रिजवी, आई कैन सी अल्पना, बहुत से लोग इसमें नहीं दिखाई दे रहे हैं। उषा जी को मैं नमस्ते कर चुकी हूँ। तो मेरी तरफ से बहुत 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 प्यार, बहुत 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 ढेर सा आशीर्वाद। But so many people are surrounding me and they will not let me talk much. But whatever I know that you are a very hardworking, dedicated person. और जो ब्रेस्ट मिल्क का जो तुमसे हमने लर्न करा वो हमने आई हैव कन्वेड इट टू मेनी सेंटर कि इसकी बैंकिंग कैसे हो सकती है। तो वी विल कम टू द पॉइंट दैट यू हैव गॉट वेरी मेनी थिंग्स इन योर माइंड यू कैन कैरी आउट। तो हम लोग सब तुम्हारे साथ हैं और भगवान ने चाहा नेक्स्ट टाइम यू आर आवर, मेरे हेड पे तुम रहना, हमारे ऑर्गेनाइजिंग टीम में तुम्हारा नाम होगा और हमारी उस टीम में तुम्हें देखने का मेरा बहुत मन है। वाई? बिकॉज यू आर वेरी टैलेंटेड। अल्पना, डू यू एग्री विद मी? डॉक्टर रिजवी एंड उषा जी, आई कैन सी ओनली 3 पर्सन्स ओवर हियर। मेरा बहुत 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 ज्यादा आशीर्वाद।
मीरा मैडम नमस्ते। भारती हेयर, आपका आशीर्वाद चाहिए मैडम। भारती माहेश्वरी।
अरे अब तो
नमस्कार
ये
मीरा मैडम।
माय गॉड।
Hello, Archana. Welcome. Welcome, my dear.
नमस्ते मैडम। नमस्ते मैडम। बहुत बहुत प्यार, बहुत बहुत आशीर्वाद। तुम लोग छिपे क्यों बैठे रहते हो? सामने आया करो।
मैम हम सब सामने ही हैं, हम लोग आपको देख पा रहे हैं।
भारती,
हमें तो सबको दिख रहा है।
with regards to all of them and my best wishes to all of them. प्रगति, अच्छा प्रगति भी दिख गई मुझे। लव यू।
प्रगति भी है मैम, सरोज सिंह मैडम भी हैं
मैडम,
और बहुत सारे लोग।
बहुत बहुत प्यार, बहुत बहुत
नमस्कार।
आशीर्वाद। और आज की फंक्शन की मीटिंग के लिए तो बात ही अलग है, लेकिन हम मीटिंग की बात नहीं कर रहे हैं, हम बड़ी मीटिंग की बात कर रहे हैं। आई एम टॉकिंग ऑफ बड़ी मीटिंग। भाई भारती, हेलो।
Yes, madam.
मैं तो आई रियली मीरा आई एंडोर्स यू दैट वी वांट सक्सेस फॉर डॉक्टर स्नेहा भुआर and Dr. Bharti Maheshwari. I always say one thing, I don't recommend these two names because I know them. No, I recommend their name because they really have the merit to have this post. But unfortunately, I do not know why our members do not vote as per the merit. This is, I don't know why they groupism and all that. I am only a member of Foxy, but sometimes I really feel very disappointed and disgusted when such things occur. But certainly, a day will come when everything will be regularized. And I wish you all the success, Dr. Sneha as well as Dr. Bharti. Let us hope that everything goes well and you both come as Vice President of West and North Zone. Thank you very much.
Thank you very much, ma'am. Thank you.
Bharti, my love, Bharti and Sneha, दोनों को बहुत बहुत आशीर्वाद। We are all with you, we were with you and we will continue to be with you.
Thank you, madam. Thank you.
आधी रात में जरूरत पड़े, तुम्हें आधी रात में भी जरूरत पड़े, you give me a call, I'll be there.
Yes.
पर मीरा एक चीज हम लोग को इंश्योर
madam.
करनी है कि हर मेंबर वोट करे। हम लोग में बड़ी इग्नोरेंस है, वोट नहीं करते लोग। अर्चना तुझसे भी कह रही हूँ, सामने बैठी है, बड़े सुंदर बाल लग रहे हैं
I
आज
know.
तेरे। सब लोग, वी मस्ट सी टू इट दैट ऑल द मेंबर्स वोट, देन ओनली वी कैन डू समथिंग।
दिस इज ये जो है हमारी रिस्पेक्टेड उषा मैम की आदेश है। हमारी जो सारी सोसाइटीज ने ज्वाइन किया है, गाजियाबाद, बुलंदशहर, बिजनौर, फैजाबाद, फिरोजाबाद, माऊ, अकोला, अमरावती, प्लीज मैडम का ये आदेश माने। हर किसी मेंबर को अपना वोट कीमती जरूर डालना है।
कीमती
बिलीव
वोट
मी,
है, ईच एंड
all
एवरी वोट
are
is very valuable.
carry
थोड़ा
a
टाइम तो ले
lot
लिया,
of
पर I
value.
want to emphasize it. Please
Yes.
vote. Please
Yes.
vote.
I totally second it and
Thank you.
मैडम की पुकार को समझे। डॉक्टर स्नेहा भुयार और डॉक्टर भारती महेश्वरी are two pillars who have been really working tirelessly for our academic enhancement and they are from us, हमारे साथ ही जुड़े हुए लोग हैं। तो I think there is no reason कि उनको सक्सेस ना मिले। तो हमारी विशेष है एंड
Thank
उषा
you.
मैम आपने तो आशीर्वाद दिया, मीरा मैम ने भी दिया है।
Yeah.
तो बहुत
With the God blessings and blessings of our respected seniors, thank once again Madam Usha Sharma, Madam Meera ji, Meera Agnihotri ji,
Thank you.
our godmother. So thank you so much for all your words.
मैडम, हम लोगों की हमारी पूरी कोशिश रहेगी कि हमारी सोसाइटी से हर बंदा वोट करे
Yes,
और
yes.
सही बंदे को जैसा आपने कहा है वैसे वोट करें। बिल्कुल।
थैंक यू मैम।
And we can just see merit.
So let us
हम
now
किसी को force नहीं कर रहे हैं।
the very best.
Thank you. So let us now
Thank
go
you, Dr.
ahead with
Nutan. Thank you.
let
आप
us now
सबके
go ahead with-
परमिशन से
Yeah,
if
yeah.
you
Go
permit
ahead with further words of wisdom from our guests of
Yes.
honor.
Yes.
Two of them are waiting for
Yes,
since
yes. That's what I
long.
wanted.
Go ahead quickly.
थोड़ा टाइम
बिल्कुल।
ज्यादा ले
I would
लिया।
like to now welcome our two more guests of honor. Dr. Archana Verma is here, Dr. Rajesh Modi is here, and
सरोज
Dr.
भी,
Saroj
सरोज
Singh,
भी है।
our dear UPCOG President, ma'am. These
Three of
three are
them.
there.
Please go.
I would request Dr. Saroj Singh, ma'am, to just switch on her video. Ma'am,
Yeah.
please अपना वीडियो खोल लीजिए।
Not to
I'm
not to
really-
waste time in introduction, I would
नहीं,
request
उसका वीडियो खुल नहीं रहा था नूतन।
Dr.
नूतन,
Sneha, I'm
सरोज
really
का
very
वीडियो
sorry.
नहीं खुल रहा था।
I'm really very sorry that today I couldn't join with video because of some network issue.
I didn't know
But
worries.
I can see all of you, very nice, very pleasant faces of all of you and can appreciate. और मैडम उषा शर्मा और मैडम मीरा अग्निहोत्री की ब्लेसिंग्स के बाद हमारा तो कहने के लिए कुछ बचता ही नहीं है। मैम की ब्लेसिंग्स हम लोगों के ऊपर सब हमेशा से हैं और हम लोग वी आर रियली वेरी ऑनर्ड दैट we have such great persons with us, and I really appreciate efforts of Dr. Sneha for joining UP and Maharashtra together, and these joint meetings are really very useful, especially those societies which are routinely जो लोग बहुत ज्यादा actively participate नहीं करते हैं, whether it is Bijnor और बुलंदशहर, फिरोजाबाद, फैजाबाद and अकोला और अमरावती और सब लोग मिलके जो ये वेबिनार हो रहा है, that is really a word of lots of appreciation for Dr. Sneha, and all of us have listened that whether it is Dr. Sneha or our own Bharti, both of them are great academician and very hard working. We have seen both of them working very hard, so it becomes our own duty कि हम सिर्फ यहाँ बैठ के नहीं बोले, बल्कि यहाँ तो हमारी सारी सोसाइटीज के प्रेसिडेंट और सेक्रेटरीज ने भी ज्वाइन किया हुआ है, दैट ऑल ऑफ देम शुड मेक श्योर कि उनकी सोसाइटी से नॉमिनेशन भी चला जाए और वोट भी हो। सिर्फ नॉमिनेशन से काम नहीं चलेगा, वोट भी जरूर हो, so that in very soon we can see Sneha and Bharti with us as vice presidents of FOXY. And secondly, I can say that जो ये सब्जेक्ट चूज किए हैं, HDP, hypertensive disorder of pregnancy and liver disease, both of them are really very important, or many times it becomes difficult for those who are not in colleges to understand what to do, when to do, and how to prevent and what to do. These are really very complicated sometimes. So this webinar is going to benefit all of them. It will be a great learning for all of them. And before I leave, I really want to say namaskar to Dr. Rajesh Modi, Dr. Archana ji, Dr. Saida Naqvi, जिनसे हम लोग प्रगति, and all seniors who are here. So lots of best wishes for webinar as well as for the in near future. Thank you.
Thank you, Saroj Singh ma'am. Thank you so much.
Yeah.
I would now like to invite Dr. Rajesh Modi sir to just say a few words of encouragement. Dr. Rajesh Modi sir.
Rajesh Modi.
Very good evening. Thank you, Dr. Sneha Bhuyar, for giving me this opportunity to interact with all of you. You are very close to me for more than 15 years now. So definitely from my side and from Akola OBGY side, you have full support for your endeavor. Support extended to Dr. Bharti also for the North-Zone elections. It's really a pleasure to interact with so many bigwigs from the UPCOG, Dr. Usha Sharma ji, Dr. Meera Agnihotri ji. Nice to have you here in the evening with us. And my regards to all of you. Dr. Saroj Singh also, current president of UPCOG. It's a pleasure to really interact with so many people and across the state, not only the Amogs, but also the UPCOG. I am definite that you will have success with your election, both of you, yourself as well as Dr. Bharti. My best wishes and sincere regards to every one of you who are here with us in the evening. Thank you.
Thank you.
Thank you,
so much,
Dr.
Dr. Rajesh. Thank you. Thank you for your precious words. Thank you for gracing the program as well. Thank you so much.
Now I would like to invite another guest of honor, Dr. Archana Verma ma'am, to just say a few words of encouragement. Dr. Archana Verma ma'am, please welcome.
हेलो गुड इवनिंग। मतलब ये नज़ारा तो देखने लायक है कि वेस्ट सारा है और यूपी सारा है। तो मैं बहुत ज्यादा इनफॉर्मल विशेस और वो सब मैं आई वोंट बी गिविंग बिकॉज मोदी जी ने बोल दिया है और मीरा मैडम ने बोला है, उषा शर्मा मैडम ने सब कुछ बोल दिया है। सो एवरीथिंग इज डन। आई ओनली वांट टू से माय नमस्कार टू ईच एंड एवरीबडी, एवरी वीआईपी प्रेजेंट हियर एंड 33 मैंने देखे हैं फिलहाल, मे बी मोर, और बाकी जो लोग और जुड़े हुए होंगे ढेर सारे, उन सब के लिए भी। और वी शुड रिमेम्बर कि देखो इलेक्शंस में हम लोगों को थोड़ा सा तो एक्टिव होना पड़ता है और वी शुड बी वेरी एनकरेजिंग ऑल्सो बिकॉज दैट अप्रिसिएशन एंड एनकरेजमेंट मेक्स us feel very empowered. So our bestest wishes to Bharti and Sneha, और सबका प्यार ऐसे ही मिलता रहे। और यही कहूंगी, तू शाहीन है, परवाज है काम तेरा, इस ज्यादा फिक्र करने की जरूरत नहीं है, जहां से आगे और भी आसमान है। सो यू ऑल आर गोइंग टू रॉक लाइक एनीथिंग। और यूपीसीओजी में मैडम से मैं पर्सनली अभी उषा शर्मा मैडम सामने हैं, तो मैं अपना जरा सा, और सरोज सिंह मैडम भी हैं, तो अपनी अपोलॉजीज दोबारा से कह दूं कि आई कुड नॉट कम टू यूपीसीओजी। और
नाराज है अर्चना जी, हम तो नाराज है अर्चना जी।
नाराजगी मिटा दूंगी, मौका दीजिए,
बनाना पड़ेगा,
नाराजगी मिटा दूंगी। आई एम होपफुल। बस जरा सा इन बच्चों का अपने, मतलब हमारे बच्चों तो नहीं, मतलब भारती इज लाइक अ रियल सिस्टर टू मी। शी हैज ऑलवेज हेल्प मी अ लॉट। और बहुत एक होता ना एहसान है मेरे दिल पे इतने ढेर सारे। तो और स्नेहा तो इज वेरी गुड फ्रेंड, क्लोज फ्रेंड, और सबके लिए बहुत सारी विशेष। और मोदी जी आप आए और आपने इतने अच्छे अच्छे वर्ड्स बोले, सो बहुत अच्छा लगा हमें।
Thank you, Rajesh Modi ji. Thank you, Rajesh
My
Modi.
pleasure. My pleasure and a privilege
Thank
to be with you all. We are missing Dr. Chandravati and hope that she has a
Yes,
quick
Chandra
recovery.
ji is not well.
अरे नूतन, थैंक यू, सईदा रिजवी मैडम, नमस्कार, सबको बहुत सारा नमस्कार।
Thank you, my dear. Thank you so much for joining.
Thank you, Archana Verma ji. Thank you very much. So
with God's blessings and the blessings of our respected seniors and dear friends, words of guidance, we would like to thank everybody for joining this program, and let us quickly move on to the academic session. And for this I would like to invite or hand over to Dr. Nutan for this. Nutan,
Yes, ma'am.
Go ahead with the academic session quickly. Start with first talk. Thank you so much.
So with the blessings of the seniors, we are starting our first scientific session. And I would like to invite our chairpersons, dear chairpersons, Dr. Alpna Agarwal, the president of Ghaziabad Society. And we have Dr. Poonam Bilokar. She is from Amravati. Dr. Renu Gupta from Firozabad Society, and our dear Dr. respected Saida Rizvi ma'am from Firozabad Society. These are the presidents, and I welcome all our 4 presidents. Thank you for joining us. And I would request Dr. Alpna Agarwal ma'am to please introduce our learned speaker, Professor Pushpa ma'am. Please,
यार
Dr. Alpna
सईदा
Agarwal ma'am.
फैजाबाद से है
सॉरी सर, फिरोजाबाद और फैजाबाद का हमने सम्मेलन कर दिया मैम, साथ में मिला के।
वो मेरी बड़ी प्यारी है, इसलिए मैंने बता
उषा जी
दिया।
को मेरा सलाम, प्रणाम।
प्रणाम।
नमस्कार। सबसे पहले मैं ऑर्गेनाइजर्स को बहुत बहुत थैंक यू कहना चाहूंगी कि उन्होंने हम सबको यहाँ पर बुलाया ताकि इन सारे सेलिब्रिटीज के बीच में हमें भी बैठने का मौका मिला। थैंक यू डॉक्टर नूतन, डॉक्टर प्रगति, डॉक्टर स्नेहा, सबसे पहले डॉक्टर स्नेहा की, डॉक्टर उषा एंड डॉक्टर
My dear, to have you. Yes.
Ma'am, can we have the slide please to introduce the speaker, Dr. Pushpa?
Yes. Can you please share the slide of our speaker, Shivani, please?
Shiva.
हेलो डॉक्टर अल्पना अग्रवाल जी, भारती
हेलो
हैं,
मैम।
कैसे हैं आप?
हेलो
बहुत
मैम,
अच्छा लगा।
कैसे हो आप?
हाँ, मैं अच्छी हूँ।
So these are our chairpersons. Can you just move ahead with them, Shivani, please?
डॉक्टर पुष्पा का दिखा दीजिए।
हाँ, yes, इसके बाद ही आ रहा मैम, press.
हाँ जी।
Yes, please ma'am.
So the speaker for today is Dr. Pushpa Changare, जो professor and head of the department of Obs and Gynae in PDM Medical College, Amravati. She is also a member of the Board of Studies and so I request Dr. Pushpa to please share her screen and start with the presentation. As we all know that hypertensive disorders during pregnancy is one of the most common and very important topic. 2 to 8% this disorder, and it's very important to be able to predict it so that we can do the preventive measures, take the preventive measures and treat them early.
Yes, we can see.
Dr. Pushpa, please.
Good evening, all of you. First of all, I would like to thank Dr. Sneha for giving me this opportunity to share my views.
You can start.
And I feel privileged that Dr. Usha Sharma ji and Dr. Meera Agnihotri ji are here. And I extend my best wishes for success to Dr. Sneha as well as Dr. Bharti ji. I'm very happy that Dr. Sneha, she being the chairperson of this obstetric practical obstetric committee of Amogs, she usually chooses topics which are really very helpful for the practitioners because we always face these problems in our day-to-day practice. So one such topic is hypertensive disorders of pregnancy. And I'm going to share my views on screening and prevention of hypertensive disorders of pregnancy. This HDP is a major contributor to maternal and perinatal morbidity as well as mortality. It is actually a spectrum of disorders ranging from already existing chronic hypertension in the index pregnancy to complex multi-system disorder like preeclampsia, leading to complications like eclampsia, HELLP syndrome, acute renal failure, pulmonary edema, stroke, and left ventricular failure, which can be life-threatening as well. Just to brush up classification, some patients, they are already having hypertension when they become pregnant. So that is chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and some patients who are already hypertensive, preeclampsia is superimposed. We will be basically discussing the HDP including preeclampsia and gestosis. Again, briefly, the pathophysiology, basically it involves abnormal presentation, endothelial dysfunction, and systemic vasoconstriction, which involves most of the or almost all the important organs in the body, including the placenta. Coming to screening and prevention of HDP, it primarily involves early detection through risk assessment and lifestyle interventions. Screening tools like the HDP gestosis score can help identify women at risk early in pregnancy, while preventive measures like low-dose aspirin and calcium supplements can reduce the risk of preeclampsia. So the screening strategies includes history taking, and so many other things which we'll see one by one. So when we are taking history of patients who are coming for antenatal checkup, certain key risk factors, they should be kept in mind. So we have to ask about previous history of hypertensive disorders in a previous pregnancy. These patients, they are more prone if there is family history of hypertension in their parents or siblings. When a patient is exposed to this chorionic tissue or pregnancy for the first time, and especially when she is adolescent or when she is elderly, again, the chances that she can become hypertensive or develop preeclampsia, they are quite high. Obesity is another risk factor. And if the patient is already having some autoimmune diseases, she is a very at a higher risk to develop preeclampsia. Coming to measurement of mean arterial pressure, it can be a useful biophysical marker in screening for a preeclampsia, particularly when combined with other factors. While MAP alone has limited predictive value, its inclusion in a multivariate model alongside maternal characteristics and biomarkers like uterine artery PI and placental growth factor improves screening accuracy. Uterine artery Doppler. Uterine artery Doppler analysis is well studied in the second trimester of pregnancy as a predictive marker for preeclampsia. The second trimester uterine artery Doppler studies at 18 to 20 weeks have shown 70 to 80% detection rate for late onset preeclampsia and 30 to 40% early onset preeclampsia in this high risk patients. It has a high negative predictive value of 92 to 94%. That means if this is normal, the findings are normal, the chances that the patient will develop preeclampsia, they are very less. Newer screening test includes first trimester Doppler of uterine artery also. It performs better in prediction of early onset than late onset preeclampsia. As an isolated marker of future disease, its sensitivity in predicting preeclampsia and fetal growth restriction in low-risk pregnant women is moderate at 40 to 70%. First trimester uterine artery PI combined with maternal characteristics could predict 45% of preterm preeclampsia at a false positive rate of 10%. Then coming to biomarkers, several biomarkers can be used to predict hypertensive disorders of pregnancy. This include placental growth factor, soluble FMS like tyrosine kinase 1 receptor, and pregnancy-associated plasma protein, that is PAP-A. Metabolomics analysis of first trimester serum can also identify early biomarkers for preeclampsia. Many biophysical and biochemical parameters are studied for predicting preeclampsia. They are still under evaluation and will require technical skills which may not be universally available and may not be feasible in many parts of our country. These are biochemical parameters like vascular endothelial growth factor, like tyrosine kinase and PIGF. Similarly, soluble endoglin is a factor which can be studied to predict preeclampsia. Glycosylated fibrinoactin. These markers in combination increase the predictive value but are not cost effective at present. So there are many markers used to improve predictivity but have not proven to be consistent, while it is clear that maternal characteristics combined with biochemical and biophysical markers are most sensitive in predicting preeclampsia than maternal characteristics alone. There is currently insufficient evidence to support a recommendation of any particular approach. Whatever I have described, we have to see them all together, put together, and then decide. Universal screening is actually recommended, but there is no single effective screening test, and none of these tests proposed till date to predict the at-risk population for preeclampsia qualify to be recommended for general population screening. With large population which is coming to us, it is definitely difficult to go through all these predictors or screening tests, and therefore assessment of clinical risk factor help us to be more vigilant. A careful history taken early in first trimester can warrant attention for effective prediction and prevention towards mothers at risk very early. At the beginning, I have told you what are the key risk factors, so they should always be asked whenever we are dealing with the patient for the first time. And this can be done by any health worker by using HDP Justosi score. So coming to this important justice score, what is this? It is effective and feasible prediction method to predict preeclampsia. It assesses the clinical parameters for screening and prediction of preeclampsia, and it can be objectively performed by easy to use HDP justice score. This score involves the existing and emerging risk factors in the pregnant woman. Then score 1, 2, and 3, it is given to each clinical risk factor as per its severity in development of preeclampsia. With careful history and assessment of women, a total score is obtained from time to time. And whenever we see that the score is 3 or more, then it can be predicted that this pregnant woman should be marked as at risk for preeclampsia. And she is a candidate to receive certain prophylactic measures. This score is simple, non-invasive tool that helps identify women at risk for preeclampsia by considering risk factors like age, medical history, and obstetric history. A score of 3 or higher may indicate a higher risk, prompting further evaluation. So these are the patients who are having 3 or more score who can be subjected for further evaluation so that we can strengthen our doubt that this patient can or may not develop preeclampsia. So this risk factors, there are 27 risk factors. Each is given a score. So age older than 35 years, score 1. Age younger than 19 years, maternal anemia, obesity with BMI more than 30, primigravida, short duration of cohabitation, that is, if the patient has become pregnant with very short duration of her marriage, she is a candidate having a risk factor 1. Then woman herself who was born as small for gestational age when she was born, this also adds to risk factor. Although the risk score is low in this definitely when we add up multiple things together, that will definitely give us a clue. Then whenever there is family history of cardiovascular disease, especially hypertension in parents or siblings, then presence of polycystic ovarian syndrome before the patient has become pregnant, then interpregnancy interval more than 7 years. That is, if there is a large gap, maybe by this time she might have become elderly now, following her first delivery. Then a patient who has conceived with IVF or ICSI treatment, when the mean arterial pressure is more than 85 millimeters per Hg, if the patient is suffering from some chronic vascular disease, dyslipidemia is there, and when patient has had excessive weight gain during pregnancy. Then there are other risk factors which are given a higher score, like presence of hypothyroidism in the mother, family history of preeclampsia, that is, if a mother or close relatives or sister, they might have suffered from preeclampsia during their pregnancy. Patient who has developed diabetes mellitus in the present pregnancy, obesity with BMI more than 35. BMI more than 30 or 30 to 35, it has high risk score of 1, but if it is more than 35, it becomes 2. When patient is carrying multifetal pregnancy, and if the patient is already having history of hypertension during her previous pregnancy, the score is higher, risk factor score is higher. Then still further risk factors are pre-gestational, that is, patient is already having diabetes mellitus prior to her becoming pregnant. She is already a hypertensive woman. If she is suffering from any mental disorders, if she is having inherited or acquired thrombophilia, if she is having chronic renal disease, chronic kidney disease, and if she is again having already autoimmune diseases like SLE, EPLA, or rheumatoid arthritis, and patients with ART, with worm donation or surrogacy. So all these 7 factors, they are quite high risk factors. And when we add up this score and we give this score, find out the gestation, gestosis score. If the score is 3 or more, we can label her as a patient at risk of developing preeclampsia. So healthcare providers assess individual risk factors at the first prenatal visit to identify women who may be at higher risk for HDP. I would like to share this score is basically developed by Dr. Gorakh Mandukar, and he has also developed an app. So anyone can download this app, and then we can come up with this 27 risk factors. We have to only interrogate the patient and examine and find out where she falls in this risk assessment. So this is a very helpful Justosi score, which without going through all the biomedical markers in each and every patient, or without subjecting the patients for sonography by sonologists only, when we come across a patient who is having a Justosi score of 3 or more, then definitely this patient can be further evaluated. So it is going to be more cost effective when we evaluate the patients who are having a score of 3 or more, Justosi score of 3 or more. Then other important things are early detection. Early detection through careful history taking and screening can lead to prompt management and potentially prevent severe complications of this justosis. Blood pressure monitoring. Every visit, the patient should be subjected for blood pressure monitoring, and it should be done throughout pregnancy. So this is crucial for detecting elevated blood pressure, and it is a key sign for detecting HDP. Then we can stratify these patients into low versus high risk groups. Then what is the role of prediction models? The Fetal Medicine Foundation algorithm is a risk assessment tool used in prenatal care to predict the risk of preeclampsia in small for gestational age fetuses. It combines maternal characteristics, medical history, and biophysical and biochemical markers to estimate the likelihood of these complications. Coming to prevention, the general preventive measures include changes in the lifestyle. The lifestyle of the patient should be healthy, which should include a proper balanced diet. She should regularly exercise and see to it that there is no excess weight gain. And of course, early antenatal care and regular follow-up, they are most crucial things to be followed. So after we find out that these are the patients who are at risk, with the help of Justosi score, it is quite easy. And then those patients who are at high risk, they can be subjected for further biomedical markers and sonography. And then we can definitely find out that who are the women who are at risk. And then they should be given some preventive measures. Like one of the important thing is they can be put on aspirin. The dose is controversial, whether it should be 75 to 150. The optimum dose is still unclear. Studies have used right from 160 to 150. Low dose aspirin has a good maternal and fetal safety profile. Number of patients exposed to doses over 100 milligrams is low. That is the study carried out in patients who were given 100 or more, it is low. The safety of prevention based on 150 milligram of aspirin per day has to be confirmed. So it is quite safe to start with 175 milligrams. And although the studies, they are more commonly carried out in patients who have put on 75 milligrams, ISHRAE usually advises 150 milligrams. If you come across a sonography report by sonologists, they usually advise that this patient should be given 150 milligrams aspirin as per their prediction of calculation of PI of uterine artery. This aspirin tablets are as easily available and they are easy to prescribe. When they should be started? Now, aspirin for this indication should be started even earlier than 12 weeks as defective placentation is considered as a causative factor of preeclampsia. So we need not wait till 12 weeks. As soon as we know that there is cardiac activity, we can put the patient on aspirin. Early aspirin balances the levels of thromboxane A2 and prostacyclin, which will maintain adequate uteroplacental blood flow and improve placentation without increasing the risk of adverse maternal and perinatal outcome. Low-dose aspirin taken from early pregnancy until birth can significantly reduce the risk of preeclampsia in women at increased risk. Moreover, it appears safe to use low-dose aspirin as a prophylaxis to prevent preeclampsia throughout pregnancy till 37 weeks or until 2 days prior to delivery, whichever is earlier. If the patient reports late and we calculate that she is having a high Justosi score, then the chances that we will be able to prevent preeclampsia by starting the maybe in mid-pregnancy or even later, they are doubtful. So if we want to start, it is better to start as early as possible, as soon as we confirm that there is cardiac activity. Another preventive measure is starting calcium supplementation. It may also reduce the risk of preeclampsia, especially in women with low calcium intake. The recommended dose for women with low dietary intake is definitely we can give it as much as 2 grams per day. So minimum 1 gram should be given, but with women with low dietary intake of calcium, it can be given as high as 2 grams. And WHO guidelines supports its use to reduce preeclampsia. Healthy lifestyle, maintaining a balanced diet, regular exercise with, of course, doctor's approval, provided she is not having any contraindications to carry out the routine exercises. Limiting salt intake, that is limiting means only limiting. We should not do away with salt because then it is going to affect the taste and patient may not eat sufficiently. So extra salt definitely should be avoided. Avoid smoking and alcohol. This can contribute to a healthy pregnancy and potentially reduce the risk of HDP. Prenatal care definitely is very much important. Regular prenatal appointments are essential for monitoring blood pressure, assessing risk factors, and receiving guidance on healthy lifestyle choices. And of course, we cannot negate the regular BP monitoring, urine protein estimation from time to time, and in later pregnancy, fetal surveillance via Doppler and growth scans. Sometimes we come across that some baby is showing lag in the growth. Patient is normotensive, but at a later date, maybe after 2 to 3 weeks, when we detect that the baby is not keeping pace with the growth, or there is some disturbance in the color Doppler, at a later date, we definitely will be able to detect hypertension in that patient. Initially, she may not be hypertensive because hypertension, sometimes it is a late manifestation. The underlying disease is already there. And one of the manifestation might be IUGR. Then to prevent severe outcomes, early referral for complications and manage severe features with help of antihypertensives and timely magnesium sulfate. And of course, timely delivery planning. Early screening and risk stratification is definitely crucial. Aspirin and calcium are key interventions and surveillance ensures safe outcome. So take-home message will be identify and monitor high-risk women at the outset, start prevention early, and follow evidence-based guidelines. Thank you for your kind attention.
Thank you, ma'am. And I would now invite Dr. Renu Gupta ma'am to give her concluding remarks. Dr. Renu Gupta ma'am, please.
Good evening, all the seniors and my respected colleagues and my juniors. I am audible?
Yes,
Yeah.
please go ahead.
Yeah, okay. Thank you, Dr. Nutan, give me this opportunity. And Dr. Pushpa already covered all the aspects of this SDP, but I summarize this. Prevention is always better than the disease. So in the prevention to SDP, when the lady plan for the pregnancy and she is in the high risk group, then she should start the when she in the first trimester or when she wants to conceive, she start the exercise, lose the weight, lose the obesity, avoid the alcohol, avoid the tobacco, and if she's already have hypertensive or chronic hypertensive, she should take less intake of the sodium, more potassium like in the fruits. And when she conceive and then in the prenatal care, then she should go regular visit for the prenatal care. She should take the prenatal vitamins, BP monitoring regularly, avoid the stress. And as Dr. Pushpa is saying, the gestosis score is very important to scrutinize these patients who is in the high risk group. So we should take care of them extra precautions. So in the first trimester we should BP monitor the BP, and the risk factor we calculate by the color Doppler of the uterine artery and the PEPA level of the biomarker. This is the placental growth factor, PIGF. So we should screen out these high risk patients, and then we do the gestosis score of these patients and monitor these patients regularly. As they reach to the 20 weeks, then regular monitoring of the blood pressure, amniotic fluid, ultrasound, and everything, and weight gain. And when then we start, if they are in the high risk patient, then we start the aspirin we should start aspirin from the 12 weeks also, or before 12 weeks also, and oral calcium supplement also.
Thank you, ma'am. Thank you. With this, we conclude our first scientific session, and we move on to our second scientific session. I would like to
One question.
introduce.
One question. Excuse me, one question from Dr. Pushpa. Should we start calcium even before 12 weeks? Normally, we start after 12 weeks.
After that is the problem is with hyperemesis. That is why we don't start the supplements in the first trimester. But if the patient is able to tolerate, definitely we can start as early as possible.
That's a perfect term, and Madam has already stressed upon it. High dose calcium right from early pregnancy. That is what we have been practicing also.
Thank you.
Dr. Sneha, Dr. Parag Biniwale sir has
Yes,
joined. Welcome, sir.
yes.
Neha, I want to leave.
Yeah,
Hello.
yeah. Hello,
Because
Madam Saida. Yes, Madam.
I want to leave because I am having one waiting cesarean section.
Yeah,
So,
please go
but
ahead.
in the end, I would like to, before that, I would like to congratulate you and wish you all the very best for your elections because you are a very deserving candidate. And I would like everybody to vote and support you. We want such persons in our association. Thank you so
And
much.
Bharti too.
With all
Madam
my
and
regards,
Bharti.
with all my regards to Usha ji, Meera ji, and all the seniors, and love to juniors. Leaving.
Thank you, Saida madam. Thank
So
you.
much. So I would just quickly invite Dr. Parag Biniwale, who is the chair of ICUG and of course a very dear friend. And here he is, joining in the capacity of national coordinator. So we would like to hear from you, Dr. Parag.
Thank you, Sneha. Good evening. I bring greetings from Amogs, and it's indeed a pleasure to be sitting here as the national coordinator of our state body, Amogs. Amogs is what UPCOG to all our friends in Uttar Pradesh. First of all, Sneha, congratulations to you and the committee for taking up this important subject, hypertensive disorders. I did to Dr. Pushpa Jungare's lecture, and it was wonderful. And she gave a lot of emphasis about the gestosis score. In fact, it was Foxy ICOG gestosis GCPR, which we had initiated in 2019, which really still holds true, and it's so important and relevant for our country. Hypertension, sure, I'm looking forward to Bharti's lecture on management of hypertension, and of course, the panel discussion which you're going to moderate on liver disorders. I'm sure it's going to be a great learning experience for all of us sitting here. Thank you for the invitation and best wishes to you and to Bharti for your forthcoming elections. And
Thank you.
Thank you, Parag. Thank you so much for joining and your precious words.
Yeah, thank you.
Thank you. So now we quickly move on to the second talk, and I think Pragati, please introduce the chairpersons.
Hello. Good evening, everyone. The second session is the management of HDP. Topic is management of HDP.
Yes, the chairpersons.
And the speaker is our own Dr. Bharti Maheshwari. The chairpersons are Dr. Geeta Bhusari. She is the president Akola Society. And thus, should we show her CV? Shivani, can you show her CV? You can float her CV only.
Yeah. All the chairpersons at a stage you can introduce. Okay. Shivani, go to, yes. Dr. Geeta,
Yes.
welcome.
Geeta Bhusari, she is
Thank you, ma'am.
Director inside Fetal Medicine Center, and she has done MBBS GMC Nagpur and MD from Solapur. Second chairperson is Dr. Akika Singh. She is the president of Mau Society. She has done diploma in reproductive medicine, Homerton University, London. Now I invite the Dr. Geeta to introduce Dr. Bharti Maheshwari.
Thank you, Pragati ma'am. Yes. Good evening, respected seniors and dear friends. It's an honor actually to be a part of this webinar. I thank Dr. Sneha Bhoyar madam who gave us the opportunity to Akola OBGY Society to be a part of this seminar. I am pleased to introduce Dr. Bharti Maheshwari, who is professor and head of Department of OBGY Department of Obstetric and Gynecology, Muzaffarnagar Medical College. She is president of Meerut Obstetric and Gynec Society, president ISOPAR, and secretary of UPCOG. In past also, she has held many prestigious posts like like National Coordinator of MTP Committee and the Coordinator of Endocrinology Committee and Public Awareness Committee. So over to you, Dr. Bharti Maheshwari, ma'am, for your topic. Yeah.
Thank you, madam, for kind introduction, and thank you, Dr. Geeta. So first of all, I would like to congratulate Dr. Sneha that she has initiated this process, and she had actually started this in the last year. So it is very opportunity to meet all the seniors from the Amogs as well as from the UPCOG, and it is really a proud moment that our seniors like Padam Shri Professor Dr. Usha Sharma Madam and Dr. Meena Madam and all seniors, they came, and Dr. Parag also. And after the other regards to all society president and secretaries, and also from Amogs, Amravati and Akola Society of Parents, and all of the bearer of Amogs. So comes to the topic what is given to me, that is management of HTP. So as I was MTP committee chairperson, you all know, so we have done lots of work together. We have given lots of regards. So I request you all, you please continue to shower me your blessings and supporting my candidature for 40 Vice President from North Zone this year. So pre-eclampsia management. And before starting, thanks to and really congratulations to Dr. Nutan Upadhyay and Pragati that they have done such a difficult task, so mostly coordinating to all society. So comes to pre-eclampsia management. Already, all we know that what is the pre-eclampsia. I'm not going in the detail about. We all know the risk factors of pre-eclampsia. We all know the pregnancy-related risk factors of pre-eclampsia. But one thing we all should remember that most cases of pre-eclampsia, they occur in healthy nulliparous women with no obvious risk factor. So in every antenatal patient, the suspicion as well as anticipated will be done. Then before starting to management, diagnostic criteria, recently what knew about that, we all know the diagnostic criteria when blood pressure more than 140/90 after 20 weeks of gestation and at least 4 hours apart, preferable. And but when it is higher, more high blood pressure like 160/110, then can be confirmed within a short interval, not you have to wait for 4 hours, so that you too can facilitate timely antihypertensive therapy. Then comes to the with pre-eclampsia always association of proteinuria. So what is that? That 300 milligram of more per 24-hour urine collection or protein creatine ratio of 0.3 milligram per deciliter. And if you are seeing by dipstick, then reading of 2+. Then diagnostic criteria of pre-eclampsia. Now I want to give you a message that in absence of proteinuria, also we have certain diagnostic criteria of pre-eclampsia. So hypertension is always common factor. Then even in absence of proteinuria, when new onset hypertension, having the thrombocytopenia or renal insufficiency or impaired liver function or new onset headache and unresponsive to medication. And this is also a diagnostic criteria of preeclampsia. So nowadays in the new classifications, we have only 4 things: chronic hypertension, gestational hypertension, preeclampsia, and preeclampsia superimposed on chronic hypertension. Difference with the previous past classification, now PIS term is evident. Eclampsia was removed from the major classification, and now we say HTP means hypertension in pregnancy. And rest, I have already told that without proteinuria, we can have with the features of either maternal organ dysfunction or uteroplacental dysfunction. One can have preeclampsia. Another very important thing is that the mild it is removed, and now we have only 2 categories, either non-severe or severe preeclampsia. And beside that, the definition of early onset type is that which appears earlier than 34 week gestation. So new versus already I have told you. Now come to the gestational hypertension. We all know the gestational hypertension when hypertension develops after 20 weeks of gestation. But one very important thing is that blood pressure level return to normal in the postpartum period. So this is the criteria. And then why it is important? Because up to 50% of women with these gestational hypertension eventually develop proteinuria or other end organ damage, and they consistently with the diagnosis of preeclampsia lined up, and this progression is more likely when hypertension is diagnosed before 32 weeks. So we must have close monitoring for the cases of gestational hypertension. Although investigators have reported a higher perinatal mortality in women with non-proteinuric hypertension compared with proteinuric preeclampsia. So this is very important thing. Women with gestational hypertension who present with severe range of blood pressure should be managed with the same approach as for women with severe preeclampsia. Then severe preeclampsia, we all know these criteria, like when hypertension more than 160 by 110, proteinuria more than 5 gram per 24 hours, severity symptoms, right upper quadrant or epigastric pain, headache, blood pressure, or elevated liver enzymes, creatinine, thrombocytopenia. So mild versus severe, this is non-severe and severe criteria. When these features are present of severe criteria, it is called severe preeclampsia. So BP is not always dependable indicator of severity. If BP is less but other features are present, multi-organ involvement, it will be the severe. So which urine test and relevance? This is a very important question when we start the management. So always remember that dipstick, it is affected by urine concentration, highly variable, but detection of urine albumin more than 300 milligram per day, 1 plus approximate albumin excretion of 30 milligram per day. So, if you are considering the dipstick, then of course 2 plus. Besides that, urine protein creatine ratio, I have already told you. Proteinuria during pregnancy, we all know that its level, but when quantitative method are not available or rapid decisions are required, a urine protein dipstick reading can be substituted. A test result of +1 proteinuria is false positive in 71%. Compared with 300 milligram cutoff on 24-hour urine collection, and even 3% proteinuria test result may be false positive in 7% of cases. Using the same 24-hour urine collection standard, the false negative rate for urine analysis is only 9%. So if urine analysis is the only available mean of proteinuria, then overall accuracy is better using 2 plus as a discriminant value. Screening methods, they already told, so I am skipping that, but we all should know what is the saving. So come directly to the management. This is very common situation when a young woman comes to second gravidancy of 28 weeks of gestation with antenatal visit, and you found routinely her on the blood pressure 150 by 100. So ideally, what should be the approach? If such happens, of course, repeat blood pressure after 4 to 6 hours, check for the proteinuria. These three things has to be done. If proteinuria, or then again, if proteinuria is present or not present, on the basis of you classify the diagnosis. Now, and beside the what important points you have to elicit in the history, age and parity, history of hypertension, family history, race and ethnicity, history of diabetes, thyroid, anemia, because hypo or hyperthyroidism, they are related to hypertension. History of twin, molar pregnancy, hydramnios. Please, when these always remember that these diseases also. And then clinical examination, the general examination is always important. Beside routine examination, thyroid, CVS, and JVP, dyspnea, tachypnea, of critical examination, more than period of gestation is found in twin polar hydramnios. And less than period of gestation, you can find out in the FGR, which is commonly associated with preeclampsia, or the woman having the antihypertensive therapy. Now that comes to the management. So what what are our aims? Of course, the first step is we have to confirm the diagnosis, what type of HTP it is, and then rule out severe hypertension. And you can observe the patient by admission for 48 hours. During the period 4-hour leave, the patient has to be taken the CBC, urine albumin, LFT, LDH, aspartate enzyme, and coagulation profile and fundus examination should be done. How frequently investigation has to be done? Of course, urine albumin daily. If mild, without end organ damage, then she can be allowed to go home. All investigation once a week or fortnightly according to severity, except blood parents, BP and urine albumin should be daily, and others can be done either on the weekly or fortnightly. Daily fetal movement counts. The woman should be told very clearly that in the 1 hour, if she has to do 10 in 24 hours or more than 3 in 1 hour, she has to check for 3 times a day. And beside that, the other methods of fetal surveillance and SCBP, umbilical artery, cerebral artery, according to note has to be done. Frequency can be increased according to severity. What are the danger signs of reporting immediately? And once you ask the woman to go home, she should be told that if she's having headache, upper quadrant pain, visual disturbances, decreased output, history of conversion, respiratory system, respiratory symptoms, nausea, vomiting, blindness, she should be repeated immediately. Now, in this case, it's particularly when to deliver, then data suggests that without severe feature, the balance should be in favor of continued monitoring until delivery at 37 weeks of gestation in absence of abnormal antepartum testing, preterm labor, preterm pre-labor rupture of membrane of vagina, bleeding for prenatal benefit. So you should you can carry the pregnancy symptom. Mode of delivery, of course, you can be in women with gestation, hypertension or preeclampsia should be written by a routine obstetric consultation. Any role of elective cesarean, the evidence is that in the non-severe cases, there is no role of elective cesarean. Anesthesia consideration with improved techniques, it is said that in the past, leakage renal anesthesia has become the preferred technique for women with preeclampsia with severe feature and eclampsia for labor and delivery. A secondary analysis of women with preeclampsia with severe feature in a randomized trial of low dose has been reported that epidural anesthesia was not associated with increased risk of cesarean delivery, pulmonary edema, or renal failure. Now, antihypertensive drugs in this particular case. So, role of antihypertensive drugs. Most obstetrician would like to start antihypertensive drugs after blood pressure reaches 150/100, thinking that this will prevent the progression of mild disease into severe and also prevent the complications like severe hypertension, abruptio, IUD, cardiac failure, pulmonary edema, and cerebral hemorrhage. So methyldopa now, first line of drug is labetalol, but it is said that it was actually most widely used antihypertensive drug, and on the longest follow-up, it is found to be safe, but it has been submitted to many control trials that during pregnancy has been shown to have beneficial effect. So in the mild hypertension, now it is replaced by the labetalol. You can give it, but calcium channel blocker like nifedipine, it is also being used. And so this was about the case what I have discussed. Now the second case, when the 32 years old multi-para with 32 weeks of gestation has come to casually blood pressure 160/100 and with headache and albumin is 2+. So again, it is the severe preeclampsia. The additional point to be history, you have to be asked that especially the urine output, history of conversion, pain, headache, excessive weight gain, and any history of antihypertensive drug taking, any history of restlessness and renal disease. Clinical feature of severe PET, we all know, so we should be taken care of and taken seriously the headache, visual disturbances, as well as fundus examination is very important, and coagulation profile and liver function test and kidney function test and whole abdominal ultrasound. And in addition, we have to check the reflexes, fundus examination, and papilledema. Now, hypertensive crisis in pregnancy. What is that? It is the acute, severe, persistent hypertension more than 160/110 in the setting of preeclampsia or eclampsia. It is associated with acute and ongoing organ damage. So, in presence of proteinuria, patient is still considered as preeclampsia. In presence of thrombocytopenia, impaired liver function test, pulmonary edema, renal involvement, and new onset of cirrhosis. So, a hypertensive emergency, what it requires hospitalization, immediate antihypertensive treatment to reduce maternal blood pressure without substantially decreasing placenta perfusion and compromising the fetus and delivery of fetus as early as possible. So, aim of management in cases of preeclampsia is always termination of pregnancy with least possible trauma of the mother and the fetus. In such cases, malignant hypertension, birth of infant who subsequently thrives, complete restoration of health to the mother. So, maternal monitoring, fetal assessment in all cases of hypertension in pregnancy. We have to control the blood pressure, prevention of seizures, control of seizures, fluid balance, delivery, and postpartum care. So, maternal monitoring, we all know that every 15 minutes until the woman is stabilized, the blood pressure has to be taken, and after that 30 minutes and 4 hours in a conservative management plan. Input and output chart, full blood count, liver function, renal function test, and beside that, repeated at least daily when results are normal, but more than if clinical condition changes. And beside that, if the AST is more than 75 and ALT is more than 70, then it is definitely significant. And if more than 150, then it increases maternal morbidity. Uric acid should not be used for clinical decision making. Platelet count less than 1 lakh considered for delivery. That is an important sign, and one should think for the delivery. Clotting studies not require a platelet count is more than 1 lakh. So this was all things when we should taken care of when we do the management of the severe preeclampsia. Fetal assessment we can do by the ultrasound, CTG in labor. Woman is there. So key of management, first thing, one, we have to control the blood pressure. Second thing is prevention of complication. Third is diagnosis and management of complication. Multidisciplinary approach. And need ICU, and nowadays ICU concept is always, so we all must, such patients should be managed in the ICU and super specialist, timely referral and tertiary center. So goal of treatment is that within 1 to 2 hours, reduce mean arterial blood pressure 20 to 25%, control environment, use IV medication. This is a special situation when we need to decrease the blood pressure quickly and effectively. A single drug is better in a small intermittent doses. Combination should be avoided as it have compound side effects. So impact of acute severe hypertension on pregnancy, that they can see the emergency, obstetric emergency, and fetal death can also occur. So management depends on lowering blood pressure safely and effectively. So of course, antihypertensive drugs, mixed self, steroids, emergency resuscitation, management of life-threatening complications like CHF, pulmonary edema, renal failure. So these all are the part of management of severe preeclampsia or preeclampsia. So we must be trained in this, and we must increase our skills to manage all such cases. So now comes to the question antihypertensive. Which one, when, and how? So profile of an ideal antihypertensive, what we have to need in the preeclampsia is that they should preserve the GFR, globular filtration rate, and inner blood flow. We need which has no drug reaction. We need which has a rapid onset and offset of action. We need which have minimal hypotension overshoot, minimal need for continuous blood pressure monitoring, and frequent dose titration. So which is those that? So we have these options drug of choice when there is a emergency. So hydralazine, it is globally some places it is the first line, but we are not using it the first line. And it is not so commonly used. But if you have to use it, then of course 5 milligram IV bolus, and then you 5 to 10 milligram every 20 to 30 minutes to a maximum of 30 milligram, or constant infusion you can give. Side effects are always maternal hypertension, headache, and fetal. So second thing is that labetalol. It is in our scenarios, in our places, it is the first line drug. As the woman comes, she's having severe hypertension, we give IV labetalol 20 milligram bolus, then 40 milligram after 10 minutes, then 80 milligram every 10 minutes for 3 additional doses to a maximum of 300 milligram. I have seen many places, and in our places, if we don't monitor and we don't check, so many times the residents or doctors, they give only one bolus or two bolus, and then it is not controlled and you terminate the patient. So please learn that how to give adequate dose of labetalol. Tachycardia less common, and it is contraindicated in asthma and heart disease. Then comes to difadipine, is again good antihypertensive drug, 10 milligram per orally, repeat every 20 minutes to a maximum of you can give up to, it does by the per orally, you can give is the maximum up to 30 milligram. Cautious use with methylsulfate can feel, because it precipitate blood pressure drop, headache, or reflect tachycardia. Short acting is not approved by FDA for managing hypertension. Then sodium nitroprusside. This is not so commonly used, but I have used one with the supervision of anesthetist. They have given by the microdrip 0.5 microgram per kg per minute to a maximum of 5 microgram per kg per minute. Fetal scientific coiling after receiving for more than 12 hours. So hydralazine, of course, this is a direct vasodilator when you are using it. And labetalol, this is a very common drug, and it is a selective alpha-1 receptor blocker. Vasodilatation, decrease peripheral distances, and decrease blood pressure. On the other hand, it is also work as non-selective beta receptor blocker, so it protects heart from reflex sympathetic drive and decrease the blood pressure. So this is the important part of labetalol, and it has a good effect of heart. And then come to Cochrane reviews. They have done a 35 randomized control trial in around 4,000 women, and they found that in compared the labetalol, hydralazine, and they found that not enough anywhere to which drug is most effective. So both drugs are comparable. Effect on cerebral perfusion pressure, the labetalol in the studies, it is found that labetalol may be an important agent in the acute treatment of hypertension of preeclampsia. Its ability to reduce cerebral perfusion pressure in most cases without adversely affecting cerebral blood flow is of particular advantage in those preeclamptic who have elevated cerebral perfusion pressure. So this is the important advantage of labetalol on the cerebral perfusion pressure. So this is the labetalol algorithm. You also have this chart in your labor rooms or in your working place, where you are giving the 20 milligram repeat between 20 minutes, and again increasing up to the 300 milligrams. And if still not controlled, then of course you have to take the help of anesthesia or critical care specialist and give additional antihypertensive medication per specific orders by recommended by specialists once BP threshold are achieved and repeat this session. Every 10 minutes for 1 hour, then every 15 minutes for 1 hour, then every 30 minutes for 1 hour, then every hour for 4 hours. So this is the frequency of taking blood pressure, and so specific monitoring should be done when you are taking the avoid parental labetalol with active asthma, heart disease, or congestive heart failure. Use may cause neonatal bradycardia. So this was about the antihypertensive in the acute emergency, and the chronic and moderate hypertension. Nifadipine, of course, sustained release tablet 30 to 60 milligram can be taken not to exceed 90 to 120 milligram per day. Hydralazine again oral can be taken 25 milligram per day. Methylolol, methyl-dopa is not, now we are giving ethanol, is not using in the preeclampsia, they are contraindicated diuretics, they are also relatively contraindicated for hypertension. So they are only reserved for the pulmonary edema. Prevention of seizure, this is also very important, and we have to do by anticonvulsant for seizure prophylaxis. Intravenous magnesium sulfate, it is the important drug for prevention, and consider the need if one or more of the following feature of severe preeclampsia is present, like recurring severe headache, visual stomata, nausea or vomiting, epigastric pain, oliguria, or severe hypertension, progressive deterioration in lab blood tests such as riding creatinine or liver transaminases or failing platelet count. So use the collaborative eclampsia trial regime for administration of medicine. Loading dose of 4 grams should be given IV over 5 to 15 minutes, followed by an infusion of 1 gram per hour, maintained for 24 hours. If woman has an eclamptic fit, then infusion should be continued for 24 hours after the last fit. Recurrent fit should be treated with a further dose of 2 to 4 grams given IV over 5 to 15 minutes. Do not use diazepam, phenytoin, or other anticonvulsant as an alternative to medical in women with eclampsia. So magnesium sulfate, we all know it prevents the treatment of either fetal neural protection as well as short-term prolongation of pregnancy. So its mechanism of action on the vasculature as a calcium channel antagonist, so it decreases vascular resistance. On the other hand, cerebral endothelium, it prevents cerebral edema. As an anticonvulsant, it is an NMD antagonist, decreases effect of glutamate and increases seizure threshold. So recurrent seizures always increase the rate of infusion of methyl 1.5 gram or 2 gram per hour. Diazepam or thiopental can be added as a single dose into patients transferred to intensive care facilities with intermittent positive pressure ventilation. Then another very important complication, that is HELLP syndrome, which is related to severe preeclampsia. So always we know that when there is a hemolysis, elevated liver enzymes and low platelets, it is a HELLP syndrome. So in such cases, diagnosis is when lactate dehydrogenase is elevated to 600 or more, AST and alanine transmit elevated more than twice the upper limit of normal, and platelet count is less than 1 lakh. So it is mostly a third trimester condition. In 30% of cases, it is first expressed or progress postpartum, with up to 15% of patients lacking either hypertension or proteinuria. So in HELLP syndrome, the main representing symptoms are right upper quadrant pain, generalized malaise in up to 90% of cases, nausea, vomiting in 50% of cases. So what is the treatment of HELLP syndrome? Of course, immediate delivery is the answer. Vaginal or cesarean, platelet is less than 50,000 of cysto, altered hemostasis. Plasmapheresis is life-saving if deterioration in course of disease. Better to deliver preterm fetus than to conserve for further harm. So when we need ICU in cases of severe preeclampsia, always remember when there is a optic hemorrhage, placenta abruptio, severe preeclampsia, eclampsia, hemolysis, HELLP syndrome, chorioamnitis, acute pulmonary edema, respiratory failure, acute respiratory syndrome, acute renal failure. Fluid balance, it is the important part whenever you are managing the preeclampsia. Total fluid should be limited to 80 ml per hour or 1 ml per kg per hour. The regime of fluid restriction should be maintained until there is a postpartum diuresis. If there is associated maternal hemorrhage, fluid balance is more difficult and fluid restriction is insufficient. So lactate ringer solution is administered at rate of 60 ml to no more than 125 ml per hour unless there is unusual fluid loss from vomiting, diarrhea, diaphoresis, or more likely excessive blood loss with delivery. Do not be tempted to increase IV fluid vigorously due to polyuria. A controlled conservative fluid administration is preferred for severe preeclampsia who already has excessive extracellular fluid and that is appropriately distributed between intravascular and extravascular spaces. Infusion of large fluid volume enhances the maldistribution of extravascular fluid and so appropriately increases the risk of pulmonary and cerebral edema. However, we all know depends on the fetal maturity, prematurity, maybe this for the safety of mother, mode of delivery to be decided as per condition of mother and status of cervix. So this is the finally a logarithm that's where there is a severe preeclampsia less than 24, termination of pregnancy to be discussed, 24 to 34 week antenatal steroid treatment, and early onset of severe disease, secondary deterioration, delivery. If it is stable, then close monitoring, and then more than 34 weeks of course delivery in the cases of severe preeclampsia. Is there any role of expectant management in cases of severe preeclampsia? So what the study says that the most obstetrician would like to terminate the pregnancy in reasonable maturity of fetus within more than 32 weeks in cases of severe preeclampsia. Patient has to be treated only in the tertiary care center with the senior anesthetist, senior obstetrician as well as neonatologist. OT facility, blood bank facility, they should be available. In a rare case, when period of gestation is less than 20 weeks, 28 weeks or 1 or 2 weeks more, patient would be observed by extremely close monitoring. That is only role of expectant, and that is in every 2 hourly blood pressure, urine output, general condition, tachypnea, dyspnea, crescentious monitoring, and if necessary, everyday monitoring by investigations like hemogram with platelet count, liver function test, kidney function test, prothrombin, etc. Immediate delivery is recommended in the cases when we are having either non-reassuring fetal heart rate, uncontrolled blood pressure, oligohydramnios with fluid index less than 5, severe IUDR, polyuria, serum creatinine level of at least 1.5 milligram per deciliter, pulmonary edema, shorten of breath, headache, or right upper respiratory pain, or development of head syndrome. So this is about the third stage. Of course, tenured syntocinon and no methadone should be given. So care after delivery, we should be very careful for monitoring and proper monitoring at least 48 hours after delivery. Anticonvulsant therapy should be maintained for 24 hours after delivery, or last convulsion, whichever occur last. Antihypertensive therapy continued until the diastolic blood pressure decreases to less than 100. Monitor urinary output. If after 48 hours there are no fits, the urinary output is good and diastolic blood pressure is below 100, the woman can be transferred to the main ward to recover. Follow up 6 weeks after the delivery. And postpartum management, fully about the symptoms of the any symptom of deterioration of the blood pressures, and should the woman who deliver with severe PET, close observation for 4 days or more required. Careful review to ensure improving clinical signs is needed before discharge. So antihypertensive should be continuous as dictated by blood pressure. Blood pressure should not be allowed to exceed 160 by 110. A reduction in antihypertensive therapy should be made in a stepwise fashion. Avoid alpha-methyl dopa in breastfeeding because in labetalol, atenolol, nifedipine, and enapalin can be given. So NICE guideline 2020 says that corticosteroid for fetal lung maceration if early birth is considered likely within 7 days in women with preeclampsia, offer a course of antenatal steroid with the NICE guideline on preterm labor and birth. Do not use DEXA or beta for the treatment of HELLP syndrome. Do not use volume expansion in women with severe preeclampsia unless hydralazine is the antenatal hypertensive. In women with severe preeclampsia, limit maintenance fluid to 80 ml per hour unless there are other ongoing fluid losses. Choose mode of birth for women with severe hypertension, severe preeclampsia, or eclampsia according to clinical circumstances and women's preference. So finally, take home message is that risk factors, they should be identified in every antenatal woman and even from the preconception time. Aspirin prophylaxis before 16 weeks till delivery, it is useful. No single investigation can predict preeclampsia. Correct and frequent measurement of blood pressure should be taken, and non-optimal treatment protocol. Close monitoring at fifth center. Patient education for severity of disease. Close monitoring in non-severe also. So let's stop maternal mortality and morbidity due to preeclampsia and related complications by enhancing skill and optimal treatment. Thank you very much for all of your patient hearing. Thank you.
Thank you, Dr. Bharti. You have given a wonderful talk. Each and every aspect you have covered. And I think Dr. Akika has left the meeting due to an emergency. Now we can proceed for the panel discussion.
Yes. Just introduce the panelists and invite.
The topic for the panel discussion is liver disorders during pregnancy, and the moderator is none other than Dr. Sneha Bhuiar herself. And the panel experts are Dr. Pramila Mittal, and I think Dr. Saida has already left due to an emergency. Can we have the CV of Dr. Pramila Mittal? Shivani?
Do we have Madam joined? Dr. Pramila Mittal, has she joined?
Dr. Pramila?
No. Yes.
She is the president Buland Shahar Society. And Dr. Saida is already not there.
She's the president of the...
Now show the...
President
yes,
of the...
She is the president of Firozabad.
Firozabad Society. Okay.
And Dr. Akika was...
Okay.
Now the panelists are Dr.
Society, she just informed me that she's leaving, so we can go ahead with the panelists.
Yes. The panelists are Dr.
Is there. I'm there.
Yes, go ahead.
Yes. Dr. Pramila, can you introduce Dr. Sneha? Though she doesn't need any introduction.
No
She's
worries,
already.
Pragati. Don't waste time in that. In fact, Madam Pramila Mittal and Madam Saida Rizvi, we welcome you as the expert for this panel discussion. I'm very happy to have you. And without much ado, we go ahead with the panel discussion. I'm just displaying the names of the panelists. I hope you can see the just So these are the experts and panelists. I think Pragati, please mute yourself because I think there's a lot of noise from your side. I don't know what it is. Just mute for a while. Yeah, thank you so much. So without much ado, we directly go to the panel discussion. So friends, purposefully, I have chosen this topic, which is actually a very difficult topic. You do get cases. It's not very uncommon, but this is the one which is least discussed in any of the academic sessions, and that is why though these complications are dreaded ones, you may have maternal mortality with this, and that's a very reason I've chosen this topic. This topic we have initially I have prepared it for the Nodzoniofoxy, the Koramakanpur societies, and now I'm discussing with all of you. So friends, the liver disorders can be the pre-existing ones like chronic hepatitis B and C, the autoimmune hepatitis, Wilson's disease, primary biliary cirrhosis, and primary sclerosing cholangitis. It can be even cirrhosis, which can be non-alcoholic cirrhosis. So it can present to you before pregnancy, during pregnancy, it may be there. But there are certain liver disorders which are related specifically to pregnancy, and right from early pregnancy, vomiting, that is hyperemesis gravidarum, which presents during first trimester, may persist for some women during second and third trimester. Intrahepatic cholestasis of pregnancy, usually in the second and third trimester. Acute fatty liver of pregnancy, which is a dreaded disease with sudden hepatic failure, presents in third trimester. Preeclampsia, eclampsia, second or third trimester, and HELLP syndrome, as you know, third trimester. There can be other coincidental liver problems like acute viral hepatitis. The infections can occur anytime, gallstones and Budd-Chiari syndrome, and drug-induced hepatotoxicity. So without much ado, we start with the case-based discussion here. So we have this 24-year-old primary gravida. She comes to you at 38 weeks of gestation, and there is she comes to you, that means your tertiary care center, with the complaints of very severe vomiting, yellow staining of eyes since 3 days. She also complained of severe abdominal pain and malaise and dizziness on several occasions. These symptoms, they are not all of a sudden they develop gradually, and there's no history of bleeding or leaking. She perceives fetal movement good, that is the obstetric aspect. She was registered initially at the Anganwadi center, regular visits. There's no major illness prior, and there's she's conscious, well oriented. She has icterus, and there is mild pedal edema. Pulse rate of 84 and blood pressure is also normal, 140/80. Other system CVS and RS, there is no abnormality. Per abdominally, uterus is full term, relaxed, head is floating, fetal heart is 140, and there is no leaking or bleeding. Os is closed, infestation is higher. So what is your diagnosis? We go ahead with Dr. Vinita first. Dr.
Thanks,
Vinita,
ma'am.
yes, please go ahead.
Am I audible? Am I audible?
Yes, please go ahead.
As per details, we can notice that 3 days history, acute in onset, third trimester related to pregnancy, 3 symptoms, vomiting, abdominal pain and malaise, dizziness, 3 signs present, icterus, yellow in color, alert level is red, mild pedal edema, vitals normal and afebrile. Obstetric evaluation within normal limits. The provisional diagnosis at this stage, depending on details, will be booked emergency ANC 38 weeks G1 with jaundice with hepatic impairment under evaluation, probabilities, unique to pregnancy, either AFLP, HELP, or both overlapping each other,
Right.
or coincidental query viral hepatitis. As she reported to a tertiary care center, I will like to hospitalize her immediately.
So we will go hurriedly to the management, Dr. Vinita. Your diagnosis is perfect that it is an acute hepatic failure. The reasons may be different, right? As you said, it can be acute fatty liver of pregnancy. It can be HELP, or it can be even the viral hepatitis leading to fulminant hepatic failure, right? So how do you differentiate? Because we have differential diagnosis. We have to go ahead with the differentiation. That as already you have said that it can be pre-existing this that, but this is over a short period, right? So how do you differentiate? Definitely you said that you will admit her and go ahead with the management, so please go ahead.
So I will investigate her. Actually, the lab reports will decide the exact cause. My diagnosis, clinical diagnosis at present goes in favor of AFLP or HELP or both at present. But lab evaluation will demarcate between AFLP or HELP or overlapping. For that, we need the CBC, LFT, KFT, coagulation profile, amylase, lipase, isn't it? And after that, we can differentiate and pinpoint the diagnosis.
Okay. One investigation is missing here. That is very, very important. Purposefully, maybe I have skipped it. So I think that is the one which is very important. Okay. So you have this patient with these parameters. Okay. Hemoglobin is 11.6. TLC is higher side. Platelet count is normal. Urine otherwise is, quite normal. Urea creatinine, it is slightly on the higher side. If you can see 33 urea and 1.9 creatinine. For pregnancy, the 1.9 creatinine is very high, 0.9 to 1.2, maybe less than 1 milligram. Okay. So urea is high and creatinine is also high. The total and the conjugate bilirubin, you can see it is 4.6, the bilirubin, and conjugate is 2.5. Okay. Total protein normal, and the amino acids you can see here the 285. Okay, AST and ALT. That means SGPT and SGOT 285 and 310. PTINR is 30 and 3.12. Prothrombin time is 30, that is elevated, prolonged. And in the INR is 3.12, which should be normally 1.5 to 2. Okay. So what is your diagnosis now?
Now it goes in favor of acute hepatic failure with AFLP.
Yeah, I think madam, we can still say that it is still acute fulminant hepatic failure. We are not sure of the, exact etiology. When one more investigation comes, especially the blood glucose levels. If the patient has profound hypoglycemia, that differentiate it from, that tells you that yes, it is acute fatty liver of pregnancy. Okay, so profound hypoglycemia. So Dr. Manisha, we come to you. What is your final diagnosis now from this?
Ma'am, according to the diagnostic, the diagnosis, the lab investigations which were shown on the slide, the diagnosis goes more in favor of acute failure of liver in pregnancy. And it is mostly, it could be because of AFLP. This is the main cause for this, because hypoglycemia. And another thing is, if there is history of polyuria, polydipsia, which occurs because of impaired degeneration of vasopressinase. So this is very suggestive of AFLP. And another thing is that this is more of liver hepatorenal shutdown, which is yes. So this is more leading towards AFLP. So because but many features they overlap with HELP and other things.
Yes,
so
we will come to the differentiation. But
the transaminases are also less than 500. So again, this is pointing towards AFLP. And second thing is that the coagulation profile, it is more than 1.5. So again, it is leading towards AFLP, and
Yes, yes.
probably
That
because of
both of you have
acute pain.
discussed it very well. Such patients require urgent hospitalization and, of course, the consultation with maternal fetal medicine and hepatology specialists, right? It doesn't remain the gynecologist or obstetrician's purview anymore. So, Dr. Vanashri, can you tell us, Dr. Vanashri, do we have?
Yes, ma'am.
Yes. So, can you tell us, about the main features of each of these causes? What we thought, there can be three main reasons: AFLP, liver, the HELP, and of course the other one. So, can you tell us the features of each one of these?
Yes, ma'am. As the patient has presented in the third trimester, which is the very commonly seen, this acute type of the diseases, mostly we found them in the last trimester of the pregnancy because patient was previously totally asymptomatic and she presented at 30 weeks, 38 weeks of the gestation. And she has the basic criteria, symptoms of nausea, vomiting, abdominal pain, malaise, headache, and anorexia. So this goes more in favor of the acute fatty liver of the pregnancy. Also, we see this in the patients coexisting with preeclampsia in 20 to 40% of the patient, and also 20%
even help. Yes.
Help, yes, ma'am. But that we have to confirm on the lab investigations.
Yes.
And
Yes.
Yes, ma'am.
Yeah. Now, what I said is how we can differentiate between the various causes of liver failure. Dr. Sachin.
Good evening, madam.
Good evening.
Am I audible? Hello.
Yes, hello. Hello. You are well audible. Go ahead.
Good evening, madam. Madam, as patient has developed the symptoms gradually, in HELP syndrome, mainly the symptoms are very acute. Patient present with severe headache, nausea, vomiting, epigastric pain, right upper quadrant pain. Mostly 90% patients are associated with high blood pressure.
Yes, yes.
There is oliguria and investigations investigation which are more in favor of HELP syndrome. These are there is a mark increased. There is a thrombocytopenia, severe thrombocytopenia. There is a proteinuria, and patient liver enzymes. These are markedly raised more than twice, mainly in HELP syndrome. Whereas in acute fatty liver of the pregnancy, patient is mainly present with gradual symptoms. The patient present with gradual symptoms. These are malaise, weakness, anorexia.
Okay.
The
But the
liver
main thing
enzymes
is,
are. Hello. Yes, madam.
yes, yes. The main thing is the liver enzymes that elevated
Liver
by
enzymes.
10 times. Yes.
Yes, yes. Liver enzymes, these are elevated by 3 times. And there is a hypoglycemia.
Yes.
As there is a sudden liver shutdown,
yes.
There is a serum fibrinogen levels are also very low.
Right.
And there is high levels of serum ammonia. The two most important diagnostic lab parameters are increase in serum ammonia and there is a hypoglycemia. These are the very
Profound
two
hypoglycemia. So liver
Yes.
enzymes, see, preeclampsia, eclampsia, and HELP, they're only twice double the normal, right? But for acute fatty liver of pregnancy, they're almost 10 times. They're 500 plus always. Okay, so that is
Yes.
one. And secondly, as you very correctly said, just to endorse that, severe or profound hypoglycemia and marked elevation of the ammonia. These are the ones which are very, very, distinguishing factors for this or diagnostic for acute fatty liver of pregnancy. And now suppose for preeclampsia, there also you have double the levels of the transaminases, right? But it does not have the ammonia, which is elevated. And it is, of course, 100% associated with the hypertension. So you have very nicely differentiated it. What about viral hepatitis? How do you rule out this?
With God grace, madam, we have a liver viral markers.
Yes.
So as such a patient came across in the clinical practice, we should go for the clinic viral markers.
Right.
Usually we do HBsAg and hepatitis C. Usually we are doing that, but
Yes.
when such a patient came across anti hepatitis A and anti-hepatitis E, these are to be done.
Yes,
Mostly hepatitis E patient are also land up into the fulminant
Right, right. Hepatic failure.
liver failure,
Correct.
hepatic failure.
Yes,
So we
you are
have to rule out also these infective pathologies with viral markers.
right. So, this is just a chart showing you what investigation you should do. These are the reference ranges for this test, which may actually vary slightly between the laboratories and the population. But now the aminotransferase, see, we are routinely doing HGPT, HGOT, HGPT, HGOT. We have to know what exactly their importance is. So can you throw some light that how do you, specify the organ which is altered or the function is altered? Yeah.
Madam, mainly SGPT or ALT. This is associated with the liver. Mainly it comes from the liver. When there is a liver pathology or injury to the hepatocytes, there is a mark increased in the ALT or SGPT.
Right.
And yes, and SGOT is non-specific. It can came from the kidney or it can came from the muscle injury also or cardiac injury also.
Right.
So it should be more specific about the SGPT or ALT. These are the serum transaminase, and we have to see for the how much fold there is an increase in the ALT or AST, serum transaminases.
Right.
So in infective hepatitis, in viral hepatitis, there is a huge, tremendous increase in the both transaminases.
Right.
But in severe preeclampsia or in a HELP syndrome, there is a
Double
2 to 3 fold increase, double, twofold. And in acute fatty liver, it's almost 5 to 10 times.
Right. So just to sum up what you have already, all of you have, discussed this case very nicely. This is clinical diagnosis is acute fulminant hepatic failure. And then you have given, differentiated it from different etiology, like, the acute fatty liver of pregnancy, preeclampsia, and HELP. So even the viral hepatitis, so of various kinds. So you have very nicely said it. Viral hepatitis, so at once you can rule out, just do the viral markers, very simple, with hepatitis A, hepatitis B, even hepatitis C and E. Okay, so that, once you do that, it is ruled out. And then between acute fatty liver of pregnancy and HELP is very characteristic. Hemolysis, elevated liver enzymes, and low platelet. Very simple. It is almost in 80 to 90% associated with hypertension, though for 10 to 20% you don't have hypertension. Without hypertension also the patient can develop HELP. That is the most important thing to be remembered. And then of course acute fatty liver of pregnancy, the liver enzymes are elevated by more than 10 times, more than 10-fold. So 500 plus is the range for this acute fatty liver of pregnancy, and profound hypoglycemia and elevated ammonia levels. This is how you differentiate it from each other. So very well discussed case. Now we go ahead with the second case. Dr. Meenakshi. Dr. Meenakshi Rana, can we have some inputs from you? Do we have Dr. Meenakshi? Do we have Dr. Meenakshi, or we can go ahead with somebody else? Okay, so I think once again we can start. I think Dr. Renu Rijul Agrawal, anybody, please put on your video and volunteer for this case, because I don't see Dr. Meenakshi. So we have this, 34 weeks primary gravida with cephalic presentation. She comes to you with very severe itching. That she's maybe we can say intrahepatic cholestasis. She's diagnosed as hepatic enzymes are just borderline elevated. And when should you, she's your regular patient. Actually, she's asking you, how do you plan her course of pregnancy or timing and mode of delivery? So when will you hospitalize her? Whether you would like to induce her or wait for the spontaneous vaginal delivery? How will you proceed for this patient? And what are the deciding factors? Dr. Rejul?
Thank you, ma'am, for the question. Ma'am, since the patient is a case of ICP who is presenting at 34 weeks, first of all, we'll send all the basic investigations.
Yeah.
Hello?
Yes, yes, please go.
We'll send all the basic investigations, including CBC, LFT, KFT. We'll also send her coagulation profile,
Right.
PT, INR, ATT. And then we'll also send in ICP, we'll send her bile acids. Bile acid, according to the bile acids, we can decide whether we have to induce the patient or we can wait. Usually, if a patient is an isolated case of ICP, we do not straight away go for induction at 34 weeks.
Right. Yes.
We'll check her bile acids level. If the patient is a case of minor ICP in which the bile acids is between 10 to 39 micromole per liter, we'll induce at her term, like between 39 to 40 weeks. If the patient is a case of moderate ICP, that is the bile acids level is between 40 to 99 micromole per liter, we can induce her at 37 to 38 weeks. But if the patient is a case of severe ICP, that is the bile acids are more than 100 micromole per liter, we'll induce her at 35 weeks or onwards.
Right. So 34 weeks is the time when you consider, she should reach 34 weeks, and beyond that, you may go for induction or the operative delivery, whatever is necessary. Because
depending on the
reason, for this reason alone, there is no need for going for cesarean section. In fact, the better that she delivers vaginally if she is inducible. Otherwise, if you have to weigh the risk and benefits of waiting, because if she has complications, and of course, maybe you are afraid that she can go into coagulopathy also, or maybe because of such high levels of bile acid, the baby can be compromised, because unexplained stillbirths are known because of this high levels of bile acid, and that's the reason you have to individualize depending upon the maternal as well as fetal conditions. So very well discussed, Dr. Riju. We can go ahead. Just a simple message once again, that on just having intrahepatic cholestasis is not an indication for the premature or iatrogenic prematurity or premature induction of labor, right? Okay. So what about this? We have already discussed about this hyperemesis. Dr. Sonal, do we have Dr. Sonal? Do we have Dr. Sonal? No. I think Dr. Lalita, you can take up. Can you tell us step by step into making a diagnosis for abnormal liver test? If you have a pregnant lady and you do her liver enzymes or liver studies, liver function test, how do you identify what case she has? How will you proceed further to reach a diagnosis in this present case?
Good evening, madam. There are a battery of investigations which we can do in these patients.
Yes.
To know their status. It may be the bile acids, the blood glucose, the LDH, serum electrolytes. Most important is the 24-hour urine.
Right. Go ahead, Lalita. Hello. Dr. Lalita?
I think, ma'am, she has got disconnected.
Okay, so we can have somebody else, no problem. We can go to Dr. Vinita once again.
Yes, ma'am.
Yes,
so
please.
we will evaluate her with CBC, LFT, KFT, blood sugar levels, total bile acid. There is a controversy regarding fasting or postprandial, but nowadays it is in favor of postprandial.
Right.
Then urine routine culture, blood culture if required, serum amylase, lipase, and ammonia. Radio imaging, that is ultrasound, ANC with color Doppler, whole abdomen with color Doppler. Fetal monitoring with CT.
I think viral markers. The viral markers.
Viral markers, yes. As she's the booked one, it might be done, but we have to repeat them with added of hepatitis A, E, E, Epstein-Barr. If required, then cytomegalovirus also.
Yes, perfect. What suppose you have some patient suspected of some vascular disorders, maybe Doppler study to rule out other hepatic or portal vein thrombosis, So these are the rare ones, but you do need to go for this. If at all you find that the lab investigations are not very conclusive, maybe that in that case you may have to go for ultrasonography color Doppler to rule out the portal vein thrombosis, which is also a common cause of this. So non-contrast MRI is also done in cases of if at all you have some solid liver mass, suspected biliary obstruction, because all sorts of liver disorders we are talking about. So for this patient, the serum uric acid was 5.3, LDH was 126, the random blood sugar was 68, viral markers were negative, and then of course the ABG was showing metabolic acidosis. Now, what are the important points in the diagnosis and management? So I would just, sum up that for AFLP, it is usually, I told you that the characteristic symptoms, nausea, vomiting, the upper abdominal pain, malaise, and, anorexia, and the profound hypoglycemia. She may have tremors, sweating excessive. If you check her blood sugar, usually near 60 or even below that. So you have to repeatedly give her glucose. Large clinical overlap between AFLP and HELP preeclampsia we have already seen. That is how you do the liver enzymes and you differentiate with these different investigations. Multi-system involvement, as we said, for acute fatty liver or pregnancy, it is actually definitely a multi-system involvement. Acute hepatorenal shutdown, coagulopathy, encephalopathy, pancreatitis, even pulmonary edema, and sometimes even ARDS. So, that is how that strengthens the diagnosis of AFLP. So, how will you manage this patient now onwards? Dr. Priyanka, can we hear from you? Dr. Priyanka? Do we have Dr. Priyanka? No. Anybody can take up this question. How do you?
Ma'am,
Yes. Yes, please
it's
go
an
ahead.
obstetric emergency.
Yes.
And we have to understand why it is an obstetric emergency. It's because the basic problem lies in the liver or the fatty oxidation. So the fault lies there. So it is in the baby as well as in the mother. So if the baby cannot oxidize the long chain fatty acids, with the result, what will happen? The maternal liver is burdened, and thereby it happens that she manifests with AFLP. So the immediate management or intervention is prompt delivery of the baby, and the basic it is the prerogative of the obstetrician, the modality how she wants to deliver, but it should be as fast as possible, and assess and then see how it can be the baby can be delivered.
Yes, so prompt delivery is the treatment, because it's the babies, some enzyme deficiency, that is the and so that we have to take the baby out irrespective of the gestational age. That is what we have to, because it is the mother's life that is most important. Don't wait for maturity and all these things. Okay? So thank you so much, Manisha. We go ahead with Dr. Rijul now. What points must be kept in mind for managing such patients medically? Dr. Rijul.
Yes, ma'am. Thank you, ma'am, for the question. First of all, the management should be a multidisciplinary approach. The team should include an obstetrician, a neonatologist, a hepatologist, a hematologist, person from intensive care, anesthesiologist, and a person from blood bank.
Yes.
Second, ma'am, it is very important to recognize and categorize these patients as critically ill, and they should be managed either in intensive care or high dependency unit. We should be checking their vitals and calculate the Mayo's score, that is modified early obstetric warning score, and act accordingly. Now, since liver failure is a state of hyperdynamic circulation, we should be very fluid balance should be very actively done. We should not be very aggressive while doing the fluid resuscitation, since excessive fluid can cause hepatorenal syndrome or cerebral edema or coagulopathy. The fluid of choice is usually crystalloids. If a person is in hypoalbuminemia, albumin infusion can be done. The fluid balance is calculated by, first 10 kgs, we give 100 ml per kg, thus making 1 liter. For the next 10 kg, it is 50 ml per kg, thus making 500 ml. And for the remaining weight, it is 20 ml per kg. So suppose if we have a female of 50 kg, her fluid requirement would be 2.1 liter per day. But then again, check her urine output, we'll check her central venous pressure, and accordingly, we can calculate the dosage of the fluid requirement.
Right.
Now, if a person comes to us with an altered mental status, she's confused, she's irritable, she has decreased consciousness, a diagnosis of hepatic encephalopathy or hypoglycemia can be made. We can check her GCS, we can check her pulse oximetry, and if a diagnosis of hepatic NCAF is made, we have to consider tracheal intubation, and we can give her N-acetylcysteine, though its role is not clinically proven.
Right.
Hypoglycemia is another very important complication of AFLP. We have to check our blood glucose level every hourly. And if the glucose is less than 65 milligram per DL, we have to give a 10% IV dextrose infusion.
Perfect.
Another very important complication is coagulopathy. We have to check every 4 to 6 hourly her platelet count, PT, APTT, PT-INR, FDP, D-dimer, and have to give blood products accordingly like platelets, FFP, cryoprecipitate, either preoperatively or postoperatively. Vitamin K 10 mg IV should be given every day. Ma'am, 15% of the patients can land in acute pancreatitis, and hence we can do the medical management like nasogastric suction and analgesics. And in case if patient lands in diabetes insipidus, we can give a desmopressin.
Right. So, Dr. Lalita, I hope she joined back. Or no, Dr. Lalita, we can go ahead with I think the other panelists. We can have Vanashri or Sachin Gadekar. Okay. So
Yes,
how will you manage her obstetrically, whether you plan for vaginal delivery or go for the elective seizure immediately and go ahead?
Yes, ma'am. Vaginal delivery should be the first considered mode of delivery. Elective cesarean section or even emergency cesarean section is not at all recommended as a first line of the treatment. We have to clinically evaluate such cases. We have to make the patient hemodynamically stable. Or if any coagulopathy is there, we have to arrange for all the blood products and FFPs, and then we should induce that patient. Of course, depending upon the gestational age of the patient.
Yeah, I would just stop you here. I would just say, just clarify what you had said. Basically, you have to evaluate the mother as well as the fetus.
Fetus, yes,
If
ma'am.
the mother and fetus are stable, but if when you do her, not to worsen the condition further, you do her internal examination, see that she's inducible. The Bishop score is good. Then you plan and go ahead for induction of
Yes,
labor.
ma'am. We'll do the NST for the baby, and if it is reassuring and patient on per vaginal examination, if the Bishop's is favorable, and if we expect that the delivery is likely to happen in 24 hours, we will definitely induce this patient.
Yes, but on the other hand, if you find that the mother's condition is worsening rapidly and you may lose the baby also, then that is an indication for emergency.
Emergency cesarean section.
Okay, perfect. So how will you manage this patient in postpartum period? What do you expect, Dr. Sachin Gadekar?
Madam, we have to continue her treatment in the ICU with multidisciplinary approach. All the ICU person, hepatologist, the gastroenterologist, then nephrologist have to be there. We have to strictly monitor her input and output, PTINR, her bleeding.
How
There is a
frequently you want to repeat the investigations? Every 24?
Yes. Every or necessarily for twice in a 24 hours. And we have to give her blood and blood products or cryoprecipitate. Then if she's after delivery, most these are the patients which recovers very fast. So even after in first 24 hours, there may be a decline in the serum transaminase level. It may increase or decrease. There may be a increase in the icterus, but the patient get improved after mainly 48 hours. So according to her pulse, blood pressure, urine output, and her clinical sign symptoms, we have to manage it accordingly.
Right.
Yes, madam.
So the three major causes of maternal morbidity and mortality in acute fatty liver pregnancy is mainly the coagulopathy. We said that it is a hemorrhage, fulminant hepatic failure, and acute kidney injury, right? So
Yes.
with this, we go ahead with the next case now. Simple case. We are having this 28-year-old second gravida. She presented at 36 weeks plus 5 days with a history, 3-day history of feeling unwell, nausea, vomiting, generalized abdominal pain, not confined to epigastrium. Now she complains of headache with some blurred vision, and she had excellent dates, and she's, regular menses. She's registered uncomplicated antenatal period. So BMI is 29 and previous D&E for a miscarriage. This is the only significant history she has. Clinically, when you examine, she has got drooping eyelids and appeared drowsy. Oriented to time, place, and person. There is no rash, mild fever, edema. Icterus is present, of course. And she's afebrile. She's got a mildly elevated blood pressure, 130/90. Uterus was soft and her reflexes were brisk with 1 beat of clonus. Cardiotocography was reassuring. So the fetus is well, but the mother is at problem. What is your diagnosis here? And these are the laboratory parameters I can tell you. The urine 2 plus, hemoglobin, everything else is okay. SGOT, SGPT you can see here in the range of 192 to 403. Bilirubin is 18. This is again a very clear cut case. This I purposefully put just as a quiz. Blood sugar is 64. Viral markers are negative. This is a spot diagnosis. Anybody can take up.
AFLP, ma'am.
Yes, perfect.
With
Yes. So we have already discussed AFLP, but I just wanted to, check whether all of you are there and attentive. Okay. So thank you so much. We go ahead with the next case now. The management principles, everything we have done. So we have this patient, 29-year-old patient. I think we'll have this case in short and go ahead. 29-year-old primary, she comes to you for routine antenatal checkup, and she is asymptomatic other than mild nausea. She doesn't have any symptom. Her routine antenatal investigations reveal the anti-HCV, hepatitis C antibody, to be positive, and other tests are normal. So is it a routine to do hepatitis C testing in pregnancy? That is for Vanashri.
Yes, ma'am. Ma'am, actually, I don't think anyone is doing this hepatitis C testing routinely. But what ACOG guidelines say that they recommend it in at least high risk group. You should do the HCV testing, like the patient who has a history of blood transfusions in the past, those who have come in contact with the hepatitis C case, or patient who is having HIV status positive, and patients on injectable drugs, they should definitely go for the HCV testing.
Perfect. So
Also,
it is recommended by ACOG.
yes, ma'am.
And we
Also, the Center for Disease Control and Prevention, they also recommend it routinely for every pregnant patient and in every pregnancy.
Yeah. So CDC and SCOG recommend that routinely this test should be done, but Government of India guidelines has not recommended till date. Though in fact we are trying to convince them that even all this, hepatitis C, like hepatitis B, now we are doing it routinely because it is recommended, universal screening for hepatitis B. But as of now, universal screening for hepatitis C is not recommended during pregnancy. The reason being, during pregnancy, if she comes positive, you cannot give antiviral. Okay. And that's the only reason. So I think it should be preconceptional counseling and screening for hepatitis C. That should be the best strategy. Okay. So as of Government of India has not recommended as a routine or universal screening for hepatitis C, though SCOG and CDC has recommended. Okay.
Yes, ma'am.
You have already talked about who needs to be screened. Now, WHO's hepatitis C elimination strategies, it has given us the target for year 2030, and reduction in the new cases should be 90%, reduction in the death should be 65%. At least that is what even CDC, as you have already said, that CDC advises us hepatitis C screening for all pregnant women during every pregnancy. So universal screening. And in the absence of hepatitis C prevalence data, the CDC advises universal screening pending availability of such data. See, again, the data is not available, though it recommends so. And that's the reason we have to wait for Government of India guideline. Though practically we all of us should start doing universal screening, I think, in your routine practice. So that is what about this case I wanted to tell you. So what are the risk factor for vertical transmission, Dr. Sachin? Dr. Sachin Gadekar? I think.
Hello, madam. Yes, yes. Hello.
Please go ahead.
HIV positive status is the main high risk factor for the hepatitis C also, madam.
Right, right.
And high load of viremia or high load of virus in that patient is
Right.
the most important risk factor
Mm-hmm.
for the transmission, vertical transmission.
Right, right.
And to avoid it, mostly as patient universal precaution and immediate cord clamping after delivery, whatever the route, vaginal or cesarean section, immediate cord clamping should be there. Because we can't give the antiviral treatment in during pregnancy also and during intrapartum period also.
Right. So first and foremost, as we said, though in our country, IV drug user, or I would say abuser, are not common in the women. But yes, you have to keep this in mind, maternal IV drug user also. And as you rightly said, the HIV positive patients and the patients or the women who have come in contact with the patients having viral hepatitis and or hepatitis C, and having very high load. Actually, she's having very high load. So that is what is the risk factor. Now we come to the last case. I think we'll just discuss this and do away. Should we go ahead or should we stop? Yeah. So yeah, just I think last case, we will go ahead quickly. 22-year-old primary gravida with full-term pregnancy. She is referred to you from a remote place with history of leaking since 2 days. Loss of fetal movements, pedal edema, patient is febrile. Okay. BP is 140/90 to 150/100. Reflexes are brisk. Liquor is totally drained out. Fetal heart absent. 1 centimeter dilated. 75% effaced. Membranes are absent. And these are the values. The investigations. TLC 27,000, very high. Platelet count 80,000, low. SGPT 97, SGOT 92, alkaline phosphatase 750, bilirubin 2.5. What is your diagnosis from this, by the way? Who wants to take up? I can see.
Ma'am, it's basically preeclampsia with HELP syndrome with IUD with element of septicemia also.
Yes. Is it primarily HELP or is it primarily septicemia with hepatic involvement? What do you feel?
It's primarily preeclampsia.
Okay.
With HELP because she has features of increased hypertension and all those features which low platelet. She shows that she's severe preeclampsia.
Right.
And because
So
she has
the
low
message is don't go on blood pressure levels. So blood pressure doesn't give you the indication of severity. The severity parameters, that is the alarming symptoms, alarming signs, and the laboratory parameters. So here our patient has got very much altered laboratory parameters along with infection, right? So elevated liver enzymes, low platelet count, and hemolysis. Bilirubin is 2.5. Very classical case of HELP syndrome with preeclampsia, that is hypertensive HDP with HELP syndrome. And then secondarily, she has IUFD with septicemia and DIC, right? So how do you manage this patient?
First of all, we'll stabilize the patient. Her blood pressure is to be stabilized. Her hemodynamic status.
130/90 is not much high. Okay, so even you can start managing her. Okay, so what is your priority?
Treatment, first infection. She has to be given antibiotics. Then coagulopathy, treatment of the coagulation disorder which is setting in. That has to be treated.
Right.
And to expedite the delivery of the baby.
So basically, she's got lots of infections, septicemia. That you have to treat first with very high antibiotics, preferably meropenem, piperacillin, tazobactam, right? So maybe this kind of drugs, and amoxicillin maybe to cover the gram-negative. Treatment of hypertension, that is simple because the blood pressure level is, it's only a slight increase. So tablet labetalol should be good enough. Coagulopathy, blood and blood component you have to arrange, and then along with all this supportive management, once you feel that you have adequate blood and blood components, definitely you go ahead with a delivery, of course.
Injection vitamin K also to manage coagulopathy. I was late in my last questions.
Hello. Yes, yes.
Meenakshi here.
Yeah, Meenakshi, welcome, welcome.
Vitamin K also should be given, like in full doses.
Vitamin? Vitamin?
Vitamin K.
Yes, perfect. For any liver disorder, for that matter, you give vitamin K, definitely. And of course, tranexamic acid. Yes, tranexamic acid is universally accepted to be very effective in any case of obstetric hemorrhage, for that matter. Okay, so any coagulopathy, that is supposed to be a complementary treatment. Okay, so give K and give, yes, Dr. Vinita.
I just want to mention two things. One is when these type of unbooked patients comes, we have to rectify the intravascular compartment.
Yes.
The hemoglobin levels are so many times are deceptive. And cultures to be sent before giving the
antibiotics, before starting. Perfect. And then you give the most effective, higher most antibiotic, but after you withdraw the specimen or sample for culture. Perfect. That's a very good message. And now, just to conclude, as pregnancy, all of you know that pregnancy is basically a physiological condition. So it's a natural phenomenon. So any unexpected outcome is deemed to be medical negligence. So all of us have to be very, very cautious. And that's a very reason antenatal care right from the beginning, following standard protocols and guidelines as far as the investigations is concerned. Please follow everything. Okay. Labor still remains the poorly understood or misunderstood. Nobody can even tell that this patient is going to deliver vaginally normally, because normal labor and normal delivery is a retrospective diagnosis even by the standard textbook of Williams obstetrics. Okay, obstetrics is unique, especially involving multidisciplinary approach, and this requires effective communication, teamwork, transparency, time to time communication with the patient's family, and of course documentation to optimize the patient care. So you do the care, talk to them, but you document that everything has been done. Otherwise, no documentation is good. Documentation is good defense, and no documentation is no defense. So it is very important to decide the cutoff point which patients can be managed in nursing home and which patient needs the tertiary care. So with this, I conclude our panel, and though there are many interesting cases, I would like to stop here. And friends, I just thank all of you and congratulate you for wonderful inputs from all of you. And of course, I utilize this opportunity to make a humble appeal from my side. I'm contesting for Foxy Vice President from West Zone, and I request all of your support and votes. Please do vote for me, and of course, do tell your friends, colleagues, if you feel I deserve. Thank you so much.
Thank you, Dr. Sneha, for such informative webinar. And we are supporting you. We already nominate you from my Foxy Firozabad. Yes, and all the best for your future.
Thank you so
Thank
much.
you, ma'am. Thank you, and wishing you all the best for the future.
Thank you so much. Thank you so much.
Thank you, ma'am. All the best, ma'am.
Yes, thank you, madam. Thank you so much. I once again thank all the 8 societies, president, secretary. I have already, talked to you individually and requested you also. I have acknowledged you and welcome you during the inauguration. I just want to thank all of you once again, and I thank the entire office bearers of UPCOG and Amogs, and I thank all my coordinators, Dr. Nutan Upadhyay and Dr. Thank you, all of you. Thank you so much.
So much, ma'am.
Good night. Bye-bye.
Bye-bye.